ಮಾಡ್ಲಾ ಸರ್?
ಹಾ
ಅದೇನು?
ಜಸ್ಟ್ ಯು ಕ್ಯಾನ್ ಗೋ ಹೆಡ್ ವಾಟ್ ಎಕ್ಸಾಕ್ಟ್ಲಿ ಅಂತ ಹೇಳಿ.
ಹಾ ಸರ್, ಒಂದ್ ನಿಮಿಷ ಸರ್, ಸ್ಲೈಡ್ ಹಾಕ್ಬಿಟ್ಟು.
ಜಾನ್ ಇದ್ದಾರೆ? ಹಲೋ,
ಸ್ಲೈಡ್ ಸೇರಿ ಪರ್ಮಿಷನ್ ಕೊಟ್ಟಿದೆ ಸರ್.
ಹಾ ಕೊಟ್ಟಿದ್ದೀರಾ? ಹಾ ಒಂದ್ಸಲ ನೋಡಿ ಕಂಪ್ಲೀಟ್ ಗೋ ಥ್ರೂ ಎವ್ರಿಥಿಂಗ್.
ಕಾಣುತ್ತಲ್ಲ ಸರ್, ನಿಮ್ಗೆ ಕಾಣುತ್ತಲ್ಲ ಸ್ಲೈಡ್ಸ್?
ಹಾ ಕಾಣುತ್ತೆ ಸರ್, ಸ್ವಲ್ಪ ಎನ್ಲಾರ್ಜ್ ಆಗ್ಬೇಕು.
ಎನ್ಲಾರ್ಜ್ ಮಾಡ್ತೀನಿ, ಫುಲ್ ಮಾಡ್ತೀನಿ ಸರ್. ಬರುತ್ತಲ್ಲ ಸರ್?
ಹಾ ಎಸ್ ಸರ್, ಎಸ್ ಸರ್, ಎಸ್ ಸರ್, ಕರೆಕ್ಟ್. ಎಷ್ಟಿದೆ ಸರ್ ಸ್ಲೈಡ್ಸ್? ನಂಬರ್ ಆಫ್ ಸ್ಲೈಡ್ಸ್ ಸರ್? ಜಾನ್ ಅವರೇ, ಜಾನ್, ಹಲೋ.
ಸರ್.
ಹಾ ಇದು ಮೇಲ್ಗಡೆ ಇದು ಬರ್ತಾ ಇದೆಯಲ್ಲ, ದ ಕಂಟೆಂಟ್ ಆಫ್ ದಿಸ್ ಮೀಟಿಂಗ್ ಇಸ್ ಸೆಂಡ್ ಟು ಒನ್ ಆರ್ ಮೋರ್ ಆಪ್.
ಇಲ್ಲ ಸರ್, ಅದು ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಲೈವ್ ಹೋಗ್ತಾ ಇದೆ ಸರ್, ಅದ್ರ ಸಲುವಾಗಿ ಸರ್.
ಹಾ ಹಾ ಓಕೆ. ರೋಹಿಣಿ ಮೇಡಮ್ ನಮಸ್ಕಾರ, ಜಾಯ್ನ್ ಆಗಿದ್ರಿ ಮೇಡಮ್?
ನಮಸ್ತೆ ಸರ್, ಜಾಯ್ನ್ ಆಗಿದ್ದೀನಿ ಸರ್.
ಹಾ ಮೇಡಮ್, ಹಾ ಥ್ಯಾಂಕ್ ಯು. ಸರ್ ಕೂಡ ಜಾಯ್ನ್ ಆಗಿದೆ ಸ್ಪೀಕರು. ಆಮೇಲೆ ನಮ್ಮ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಸರ್ ಇದ್ದಾರೆ. ಸೊ ದಟ್ ಮತ್ತೆ ಎಲ್ಲ ಜನ ಜಾಯ್ನ್ ಆಗ್ತಾರೆ. ಸೊ ಸೊ
ये लोग कहाँ थे, कहाँ नहीं थे, ये वापस गए या नहीं गए, नहीं गए तो क्यों नहीं गए, किसी को नहीं पता।
ನಮಸ್ಕಾರ ವೀಣಾ ಮೇಡಮ್.
बहुत तरस आता है।
ವೀಣಾ ಮೇಡಮ್ ಅವರಿಗೆ ನಮಸ್ಕಾರಗಳು.
आज में जलील होने आ रहे बताओ, और आज पैरों में गिरकर भीख मांग रहे हैं कि माई बाप हमें वापस।
ನಮಸ್ತೆ ಸರ್.
ಹಾ ನಮಸ್ತೆ ಮೇಡಮ್, ಗುಡ್ ಈವ್ನಿಂಗ್.
ಗುಡ್ ಈವ್ನಿಂಗ್, ರಾತ್ರಿ ಆಗ್ಲೇ ಬಂತೆ. ಗುಡ್ ನೈಟ್.
ಇನ್ನು ಇದೆ ಮೇಡಮ್. ಸೊ ಥ್ಯಾಂಕ್ ಯು ಮೇಡಮ್, ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ ಜಾಯ್ನಿಂಗ್. ಇದು ದಿಸ್ ಇಸ್ ಎ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಟಾಪಿಕ್. ನಮ್ಮ ಸೂರ್ಯರಾಜ್ ಸರ್ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಿದ್ರು ಈ ತರ ಒಂದು ಗುಡ್ ಟಾಪಿಕ್ ನಮ್ದಲ್ಲಿ.
ಟಾಪಿಕ್ ಮಾತಾಡಿದ್ಮೇಲೆ ಎಲ್ಲಿ ಆರ್ಗನ್ ಡೊನೇಟ್ ಮಾಡ್ತೇನೆ ಅಂದ್ರೆ ತಕೊಳ್ಳೋರು ಯಾರಿದ್ದಾರೆ, ಎಲ್ಲಿದ್ದಾರೆ, ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಮಾಡೋರು ಯಾರಿದ್ದಾರೆ?
ಅದು ಜಸ್ಟ್ ಇಟ್ ಇಸ್ ಫಾರ್ಮ್ಯಾಟ್ ಎವ್ರಿಥಿಂಗ್ ಸರ್.
ಅಲ್ಲ, ಅದೆಲ್ಲ ನಾವು ಮಾಡಿದ್ದೀವಿ.
ಹಾ ಎಸ್
ಬಟ್ ಈಗ ನಾನಿಲ್ಲೇ ಸುಳ್ಳ್ಯದಲ್ಲಿ ಸತ್ರೆ ನಂದು ಆರ್ಗನ್ ತಗೊಳ್ಳೋರು ಯಾರಿದ್ದಾರೆ, ಕಳ್ಸೋರು ಯಾರಿದ್ದಾರೆ, ಮಾಡೋರು ಯಾರಿದ್ದಾರೆ?
ಪ್ರಾಕ್ಟಿಕಲ್. ಸೊ ಇಟ್ ಇಸ್ ಎ ಪ್ರಾಕ್ಟಿಕಲ್ ಇಶ್ಯೂ. ಎಸ್ that is the reason madam, it is so much waiting list is there. So waiting list is many.
ಅದೇ ಸರ್, ಹೇಳುವಾಗೆಲ್ಲ ಹೇಳ್ತಾರೆ, ಬಟ್ ಅನುಷ್ಠಾನಕ್ಕಾಗುವಾಗ ಏನೂ ಇಲ್ಲ.
ಅದು ಕಾರ್ಯರೂಪಕ್ಕೆ ತರೋಣ ಮೇಡಮ್, ಎಲ್ಲರೂ ಕೂಡಿಸಿ ಪ್ರಯತ್ನ ಮಾಡೋಣ.
ಲಾಸ್ಟ್ ಟೈಮ್ ಇಲ್ಲೂ ಇತ್ತಲ್ಲ ಸರ್, ಗದಗಲ್ಲಿ ಅಲ್ಲಿ ಸೇಮಿನಲ್ಲೂ ಟಾಪಿಕ್ ಇತ್ತಲ್ಲ.
ಹೌದು ಮೇಡಮ್, ಗದಗದಲ್ಲಿ ಇದ್ದೆ.
ಮತ್ತೆ ಎಲ್ಲ ಪ್ಲೆಡ್ಜ್ ಮಾಡಿ, ನಾವು ಪ್ಲೆಡ್ಜ್ ಮಾಡಿ, ಅವಾಗ ಕರ್ನಾಟಕ ಇದು ಸೆಕೆಂಡ್ ಪ್ಲೇಸ್ ಹೈಯೆಸ್ಟ್ ಇನ್ ಪ್ಲೆಡ್ಜಿಂಗ್ ಎಲ್ಲ.
ಹೌದು ಮೇಡಮ್, ಹೌದು.
ಆರ್ಗನ್ ಬಿಡಿ, ನಮ್ ಸುಳ್ಳ್ಯದಲ್ಲಿ ಕಾರ್ನಿಯಾ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಗೆ ತಗೊಂಡು ಹೋಗಕ್ಕೆ ಜನ ಇಲ್ಲ.
ಅದೇ ಇಗ್ನೋರೆನ್ಸ್, ಮಿಸ್ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್.
ಇಲ್ಲ ಸರ್, ವ್ಯವಸ್ಥೆಗಳು ಕಷ್ಟ ಇದೆ.
ಗುಡ್ ಈವ್ನಿಂಗ್ ಡಾಕ್ಟರ್ ಸುರೇಶ್.
ಹಾ ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್, ಜಾಯ್ನ್ ಆಗಿದ್ದೀರಿ? ಸೂರ್ಯರಾಜ್ ಸರ್ ಗುಡ್ ಈವ್ನಿಂಗ್.
ಜಾಯ್ನ್ ಆಗಿದೆ
ಸರ್ಗೆ ಮಾತಾಡ್ತಾ ಇದ್ದೀನಿ.
ಎಸ್ ಸರ್.
ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್, ಡಾಕ್ಟರ್ ಸೂರ್ಯರಾಜ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್
ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್.
ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್.
ವೆಲ್ಕಮ್ ಯು.
ಸೂರ್ಯರಾಜು ಸರ್, ಡಾಕ್ಟರ್ ಜಗನ್ನಾಥ್ ಮಾತಾಡ್ತಿರೋದು
ಸರ್. ನಮಸ್ತೆ ಸರ್, ವೆಲ್ಕಮ್ ಯು.
ಥ್ಯಾಂಕ್ ಯು
ಸರ್. ಥ್ಯಾಂಕ್ ಯು.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
ಡಾಕ್ಟರ್ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಸರ್ ನಮಸ್ತೆ.
ಸರ್ ನಮಸ್ತೆ ಸರ್.
ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಸ್ವಾಮಿ ಸರ್ ವೆಲ್ಕಮ್.
ನಮಸ್ಕಾರ.
ಹಲೋ ಸರ್. ಹಾ ಸರ್, ಅದು ಪ್ರೋಗ್ರಾಮ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಿದ್ವಿ. ಹೌದು. ಹಾ, ಅದು ಇಂಟ್ರೊಡ್ಯೂಸ್ ನೀವು ಮಾಡ್ಬೇಕು ಸರ್. ಹಾ ಓಕೆ ಸರ್. ಈಗ ಓಕೆ ಸರ್, ಓಕೆ ಸರ್. ಸೂರ್ಯರಾಜ್ ಜಾಯ್ನ್ ಆಗಿದ್ದಾರೆ. ಹಾ ಥ್ಯಾಂಕ್ ಯು. ಓಕೆ ಸರ್, ಓಕೆ. ಸೂರ್ಯರಾಜ್ ಸರ್, ಶ್ರೀನಿವಾಸ್ ಸರ್ ಜೊತೆ ಮಾತಾಡಿದೆ.
ಹಾ ಹಾ
ಅದೇ ಅವರು ಫಂಕ್ಷನ್ ಅಲ್ಲಿ ಇದಾರೆ, ಜಸ್ಟ್ ಇಟ್ಸ್ ಇನ್ ಬಿಟ್ವೀನ್.
ಎಸ್ ಎಸ್ ಸರ್.
ಐ ಮೇ ಜಾಯಿನ್, ಮತ್ತೆ ಜಾಯಿನ್ ಆಗ್ತೀನಿ. ಮತ್ತೆ ಎನಿಥಿಂಗ್ ಅಂದ್ರೆ ಅವ್ರು ಸರ್ ಕಂಟಿನ್ಯೂ ಮಾಡ್ತಾರೆ ಸೂರ್ಯರಾಜ್ ಸರ್ ಅಂತ ಹೇಳಿದ್ರು.
ಆಯ್ತಾಯ್ತು.
ಸೊ ನೀವೇ ಇಂಟ್ರೊಡ್ಯೂಸ್ ತಾವೇ ಹೇಳಾಕತ್ತಾರೆ ಆಮೇಲೆ ಪ್ರೆಸಿಡೆನ್ಷಿಯಲ್ ರಿಮಾರ್ಕ್.
ಯು ಕ್ಯಾನ್ ಸೆಂಡ್ ಮಿ ದ
ಅಲ್ಲ, ಪ್ರೆಸಿಡೆನ್ಷಿಯಲ್ ರಿಮಾರ್ಕ್ ಸರ್ ಅಂದ್ರೆ ಜಾಯಿನ್ ಆಗ್ತಾ ಇದ್ರೆ ಎಷ್ಟು.
ಸಾರಿ ಡನ್. ಸರ್
ನಾರಾಯಣ ಸ್ವಾಮಿ ಸರ್ ಇದಿರಲ್ಲ?
ಇದೀವಿ ಸರ್, ಹೇಳಿ ಸರ್.
ಏನಿಲ್ಲ, ಅದೇ ಜಸ್ಟ್ ಸೂರ್ಯರಾಜ್ ಸರ್ ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಸರ್.
ಶುರು ಮಾಡೋಣ. ಐ ಥಿಂಕ್ ಪೀಪಲ್ ವಿಲ್ ಜಾಯಿನ್ ಸ್ಲೋಲಿ.
9:04 ಆಯ್ತು.
ಎಸ್.
ಈಗ ಒಂದು 10 minutes ವೇಟ್ ಮಾಡೋಣ ಅಂದ್ರೆ ಮಾಡೋಣ ಸರ್. ನಿಮ್ಮಿಷ್ಟ ಸರ್.
ಇಲ್ಲ, ಜಾಯಿನ್ ಆಗ್ತಾರೆ ಸರ್. ನಾವು ಶುರು ಮಾಡ್ಕೊಳ್ಳೋಣ ನಿಧಾನಕ್ಕೆ. ಐ ಥಿಂಕ್ ಪೀಪಲ್ ವಿಲ್ ಜಾಯಿನ್ ಸರ್.
ಹೌದು ಸರ್, ಲಾಸ್ಟ್ ಟೈಮ್ ಹಂಗಾಗಿತ್ತು.
ಓಕೆ ಸರ್, ನೀವು ಹೇಗೆ ಹೇಳಿದ್ರು ಅದೇ ಸರ್. ಓಕೆ ಸರ್.
Yeah, I will start. Good evening, everyone. Now we have come to the one more important session, as we are doing continuously monthly one program. So like that, today we are doing one important, which is very much needful in the society. That is where India stands now with respect to the organ donation. As all of you know, organ donation is important and it is one of the burden problems in the society. It's a burning issue, especially more in the periphery, especially periphery of the country, periphery of the city, because of ignorance, because of misconception, as Madam was telling. So because they don't know what exactly and what is the meaning of organ donation. That's why the waiting list is being waited. Many of the people with end stage disease like liver failure, kidney failures, many of the people are waiting. So with keeping their residency outside the hospital, especially in the metro city. So with this remark, we will stand. I welcome all the members of the Public Health Committee, all the members of our IMA KSP, and all the respected past president of IMA KSP and the chairmen of the other chairmen of the IMA KSP. And also I welcome our Secretary Dr. Suryaraju sir. With due respect, sir also given the opportunity for conducting such a important the topic. And I welcome the speaker of the today is Dr. Narayan Swami Mula. He is a senior most consultant and critical case specialist, and also he is a legal advisor for organ transplant. So he will tell all the our doubts regarding the organ donation. So let us proceed and let us ask many questions to sir, and sir will definitely solve and he will satisfy our problem. With this, I call upon Dr. Suryaraju sir for our IMA prayer and flag salutation. Dr. Suryaraju sir.
Good evening. Thank you, Dr. Suresh. Welcome you all. Let us start this program with IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯವಾಗಿರಲಿ. ವಂದನೆಗಳು.
Thank you very much, sir. Dr. Suraj, sir. Now I call upon once again Dr. Suraj, sir, for a presidential remark. As our president, Dr. beloved President Dr. Chinewala, sir, is busy engaged in some function. So, in absence, I call upon Dr. Suraj, sir, to give a presidential remark.
Thank you. Dr. V.V. Chinewala, because of some unexpected reason, could not able to join. Thank you for giving me this opportunity to speak on this program. First of all, I welcome this public health meeting, as today the most important burning issue in our country is the shortage of the organ. As you all aware, less than 1% of the people with organ failure patients are able to undergo the transplant. Less than 1%. When compared to the rest of the world, our rate of organ donation and organ transplantation is very, very less. Regarding this, what are the obstacles? What are the challenges? How we can improve the number of transplants? How the awareness about the transplant should go, improve or increase among our doctors? So to speak on that, Dr. Narayan Swami Moola, who is a senior most consultant in critical care, is a lead advisor organ transplant Manipal Hospitals, Bangalore. I welcome you, sir. Actually, it is a honor to it is a honor for IMA Karnataka State Branch to have you on this occasion, sir. And we want to gain maximum inputs from you, so that on that day, few days back, when I met Dr. Narayan Swami, sir, when I met him, he was telling how many doctors are suffering from the organ failure. How many doctors need organs, because of multiple factors. Okay, many doctors are also having the shortage of the organ. When I heard that news, I was really, moved. Then I thought I connected to Dr. Suresh. So we should use IMA platform, to improve, in order to create an awareness about the organ donation. So thank you very much, sir, for accepting our invitation and giving your valuable time. At the same time, so let us actively participate in this valuable program. At the same time, we will, after once this program is over, we keep discussing about the shortage of this organ donations, and forward this recorded video to other groups also. Thank you and welcome you to Dr. Narayan Swami, sir. Over to Dr. Narayan Swami Moola, sir.
Thank you, sir. Thank you for the kind introduction, sir.
One more thing, sir. I call upon Dr. Rohini, madam. She is a program director and also the senior consultant and as a member of the Public Health Committee to conduct this program. Dr. Rohini, madam.
Sir, good evening.
Please introduce our speaker, madam.
Good evening, everyone. Namaskara ellargu. At the outset, I would like to thank Dr. Suresh Kagalkar, sir, the chairman of Public Health Committee, for giving me this opportunity to moderate the session. And I'm Dr. Rohini, a Public Health Committee member. I welcome everyone for today's session, which is on where India stands with respect to organ donation. And today's speaker is Dr. Narayan Swami. Sir is graduated from MRMC Gulbarga and is done a post-graduation in anesthesia from WIMS Bellary. He's done an DNB from Manipal Hospital, Bangalore, and a critical care fellowship
Hey,
from
you
Narayana
Paralakona,
Vidyalaya.
Anirudh. Super.
Sir is a senior consultant at in a critical care advisor transplant program, Manipal Hospitals, Bangalore. As a doctors, we all know how important it is for a organ donation by saving one's life, particularly the individuals who have got a failure organs, and how important it will improve the quality of life and also bring hope to one's life. In India, it has become a very crucial issue because there are, as I already told, there are a lot of waiting cases, especially with the doctors and families, and very less people are coming forward for the organ donation. So it is estimated that 250,000 people are dying every year with the hand organ disease. So the government of India has come forward with a policy to promote the organ donation in hospitals. So with this, we are expecting to have a more number of organ donations. And today we have with us an expert on this, Dr. Narayan Swami sir, to give us more knowledge about organ donations, the types or the process of registrations, and also the laws governing it in India, and particularly in India, I mean, where the India stands for with respect to the organ donation. So over to you, sir, for your talk. Thank you, sir.
Thank you, madam. Thank you, madam. Thank you for introduction, madam. Thank you, sir, for giving me an opportunity for today's talk, sir, actually. So, as all of you know, um, organ donation is an important thing because as an intensivist, I'm an intensivist, sir. As an intensivist, I see a lot of people dying with end organ disease, probably because of the end stage lung disease, end stage liver disease, end stage renal disease, end stage heart disease, and all those things. So now, in my over 25 years of practice, what I have seen, recently I'm seeing more younger and younger patients who are dying with end organ disease. Whenever I go outside, a lot of people talk to me. I'm having this organ failure, that organ failure. What should we do? And I have seen a lot of them talking to their doctors also. What should do, sir? Where should we go? All those things. And they have young families around, small children and all. And they are the breadwinners of their family. They don't know if that breadwinner is going to die, what will happen to the rest of the family, or the children are able to have a reasonable quality of life if once their father or mother, if anything happens to them. So that all will come to my mind actually when I see all those things. That is the one part. But what I have seen recently, I was discussing with Dr. Surya Raju sir also recently. I've seen a lot of doctors in the waiting list. We, the healthcare providers, we are at the forefront to handle any healthcare problems and all, which we have seen recently during the COVID pandemic. Whatever we can do, we have done. A few doctors we lost in that battle with the COVID and all. But the thing is, unfortunately, in the waiting list, a lot of doctors, they themselves are in the waiting list. So the thing is, a last donation which we facilitated, I am proud to tell that we could able to save one urologist. He required a liver transplant. We could able to save him. The other day, we had one other orthopedic surgeon requiring a lung transplant. Somehow we got it with the help of government of Karnataka from the pool, Jiva Sarthakate and all. And there are, as per my knowledge, there are few doctors in Hyderabad and Mumbai requiring a lung transplant. They are on ECMO. They are on ventilator. They are on ECMO. They can die at any time. So this is an unfortunate situation for all of us. It can be any one of our friends, any one of their family members, or near dear and all those things. It can happen. When I meet a lot of senior consultants, doctors, like all you people, when I go outside, one thing what I have seen is there is an interest and the enthusiasm to support me and all. So the only thing they will tell, we have to create then public awareness, sir, all those things and all. That we are actually doing it from quite some time from Manipal hospitals. We are reaching out to important people like you because you are the social influencers to influence the society and all those.
We are not seeing your face, sir.
Yes, sir. Sorry, sir. Sorry, sir. So you can see, sir? No, you can see?
Go ahead,
You can
madam.
see,
Sir,
you
please
can,
go ahead.
Yes, sir. Sir, we can see, sir.
okay,
We can see
okay,
you, sir.
okay,
Yes.
madam. So now, whenever I meet people like you, I know that you have that interest and enthusiasm, time to help the society how to do it and about. As you know, a lot of people will die because of the end organ disease. Like last year's information which we got from NOTO, that is the National Organ Tissue Transplant Organization, which is a body of health and family welfare government of India. Nearly 250,000 people they die of end organ disease, waiting endlessly in the waiting list itself, waiting for their turn to get an organ. So where do they get kidney and liver can be donated by a family member. Um, all those things can be done. But what happens to the heart, lungs, pancreas, and all those things? No living person can donate part of his heart, part of his lung, part of his pancreas, and all those things. It has to come from the deceased donor, somebody who is brain dead. So the what is brain death? The person who have met with an accident, having a severe traumatic brain injury, or there are no brainstem reflexes, or somebody having a non-traumatic injuries like a spontaneous intracranial bleed, probably hypertensive bleed, aneurysmal bleed, or somebody who have a suicidal intentions, like a hanging and all those things, partial hanging, they may get admitted to our hospital. We see in and out all these patients and all. They are the important source for the organs, procurement of organs. Brain death in India, it has been legalized. It is equivalent to the circulatory death. So 250,000 organs in India require solid organs every year. The major source of organ is from the patient who is brain dead. How many of them, as per the last year, it is 150,000. There is a big gap there itself. 1 lakh difference between the requirement and availability. And then we don't always convert all of them. We always tell that no, idu bada, idu sari illa, idu general sari illa. We should not do anything. We should not talk. We should not initiate all those things. So that opportunity is lost. Such patients having a circulatory death and dies, we are going to write the death certificate. That means that we are writing death certificate for 8 other patients who are innocent. They deserve. They deserve to have a good quality of life. But unfortunately, those things are not happening. So, as I want to tell you that organ transplantation is the only definitive only definitive treatment for the end organ disease. There is no other thing where we can save patients' life. There is this is the medicine up to what we can do. This is the limitation of the medical knowledge. So what is the only thing is transplantation, organ transplantation. Without donation, organ transplantation can't happen. But there is a huge gap between the demand and supply, as I explained you earlier. So, and you know, India is the most populous country in the world. Nearly 1.4 billion population. It has crossed China. So, and we also require 250,000 organs per year: livers, kidneys, heart, lungs, pancreas, and all those things. But our donation rate, deceased donor donation rate, is very low. If you see a small country like Spain here, it is it may be the size of our Karnataka. It stands first in the number of organ donations per year. It is nearly 35 to 40 per million population, Spain. Next, followed by the Croatia, Portugal, USA, all those things, even UK, Australia, and all those things. India being the most populous country, we here you see we can't see India at all. That is the pathetic condition of our nation. So, what we can do, at least now, we can do something about it by having an awareness, interest, finding out the potential donor, all those things which we can help, and we can always discuss how to get them converted, how to get them shifted to a bigger hospital where they have licenses, where the transplants can happen, all those things. So, This is where we are standing as of now. As I told you, a living donor, like a blood relative, can donate one kidney or a part of the liver for their near dear relative. But where does the heart, pancreas, and all comes, lungs and all? It can only come from the deceased donor. Deceased donors are who? The brain dead donors. Somebody where there is no brainstem reflexes at all, but there's still the circulatory function is still there, heart is still functioning. There is a measurable blood pressure is there. You have put such patient on ventilator. So those patients are, if the GCS is around 3, no brainstem reflexes, having a uh, neuroradiological evidence like a CT scan showing a large stroke or met with an accident, having a severe traumatic brain injury, having a blood lot. So all those patients are potential donors. They are brain dead donors. There is new thing, something coming up as donation after circulatory death, where patient has come, admitted there, is not doing well, blood pressures are not recordable. He will meet the terminal event anytime and he will be dead anytime. So such patients, we can immediately initiate them, put them on ECMO, perfuse the organs, and then get the blood pressures to reasonably acceptable level, graft perfusion is maintained, and then we can retrieve the organs gradually by a process. But the thing is, there is a difference between this and this because this is legalized in India and most parts of the world. But DCD, that is a donation after circulatory death, it is not picked up in India, and there is no legal clarity to go through. But a few centers in India, like in PGH Chandigarh, some hospitals in Gujarat, they have done this DCD, but they have done renal donation, that is a kidney donation. So it may be one of the upcoming things, exciting things, but it is more expensive, and also the graft function post transplant. Is it comparable with the donation from the brain death patients? This is very difficult at this point of time for me to tell about these two. But this is the thing where we have plenty, lot of people are there who are brain dead for multiple reasons, which can be utilized for our near and dear patients. So, as you know, donation and the transplant process is a complex one. You identifying a potential donor itself is a difficult. Talking to the family, difficult times for them because you have to talk to the family when the tragedy has stuck to them. They could not able to digest that their near and dear is brain dead. Doctors are telling that is brain dead and that is equivalent to the circulatory death. Is no more. Nothing. There is a medical fatality is there. You can't do anything. Then the family might be asking, sir, can we go to the bigger hospitals? Sir, ದೊಡ್ಡ hospital ಹೋಗ್ಬೋದಾ, ನಿಮ್ಯಾನ್ಸ್ ಹೋಗ್ಬೋದಾ, ಹಾಗೆ ಹೋಗ್ಬೋದಾ, Bangalore ಹೋಗ್ಬೋದಾ? You clearly know that you can't do anything. Nothing. Even these big hospitals can do anything. So at this point of time, you clearly know, and then you try to initiate the organ donation conversation and all those things. It doesn't look nice, and the family don't take it properly, and usually when they don't take it properly, they will take the patient home, dama, and then patient will die ultimately. So one such loss is equivalent to a loss of 8 potential recipients. So that we need to keep this mind whenever we talk to the family. So here the appropriateness, when to talk, what should we talk, and who is going to talk, these are all are there. That if I get the opportunity from the IMA, next time I can do a talk about grief counseling after declaration of the brain death. So if I get an opportunity, I can talk about those things also. So the third one is, the third difficult challenging problem is the identification and the referral of the potential donors. So whether this patient is a potential donor, whether his organs are suitable, creatinine is around 2.5 and all, yeah, age around 70 years, 80 years, we get a lot of doubts. Is this really a potential donor? Can I call the transplant team? Can I disturb them at this point of time, at this hour of night? Can we call them, tell them that I have such and such a patient? Can he be a potential donor. You might be having a lot of doubts. That's why today I'm here. If at all, if you get such patients, um, uh, what to do, whether you call or not. So you might be having a lot of questions, whether suitable or not. So each organ wise, I'm going to tell whether they are suitable or not. And then, as you know, as I already told you, consequences of a missed early donor identification and referral. So 8 other patients are going to die on the waiting list. So economic loss to the society and nation, waste of healthcare resources, because these patients frequently will get admitted with respect to hospitals. They may be maintenance hemodialysis, they may be having infections, they may have some other problem like MI when they are on dialysis or all those things. So all those things will add on, which I need not mention at all. So what is our responsibility?
There's some disturbance, sir. Network not able to hear.
Hello, madam.
There's some
Network
disturbance.
issues. Not your voice is not clear, sir.
Okay.
Last
okay.
few sentences.
Okay, madam. Okay, madam. Okay, madam. Can you hear me, madam? No.
No.
Some shaking
It's the
is there.
same. John, could you help?
Maybe
Sir, you can turn off your video, sir, so the audio will be clear, sir.
Turn off.
Is it okay, sir?
It's the same, sir.
Still not clear, sir.
Okay, sir.
maybe internet issues, sir. Probably signals are.
Internet.
The Wi-Fi. Check it out, sir. One second.
ಅಲ್ಲ ಇದು ಬ್ಯಾಂಡ್ ವಿಡ್ತ್ ಏನಾದರೂ ಕಡಿಮೆ ಇದೆ? How exactly you can tell that net issue? John?
Yes, sir.
ಅದೇ how exactly ಅಂದ್ರೆ
No, sir, it is showing that their Wi-Fi is little weak, sir, for us from here.
yes, weak.
Yes, sir, it is showing as red, sir. So there is a network issue, sir, with them.
Okay, sir, no problem. You can continue. There is nothing we can do about it.
Yes, sir. Narayan, sir. ಆಡಿಯೋ ಆಫ್ ಮಾಡಿದ್ರು
ಸರ್ ಸ್ವಲ್ಪ ಚೇಂಜ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಅಂತ ಕಾಣುತ್ತೆ. ಟ್ರೈ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಈಸ್ ಸ್ವಿಚಿಂಗ್ ಓವರ್ ಟು ಸಮ್ ಅದರ್ ಸಿಸ್ಟಮ್.
You can hear me, madam? Is it slightly better?
It's a little better, sir.
Okay, sir, you can continue.
One minute, sir. I will just try, sir. I will just try to do something.
Dr. Suresh, we need to prepare a flyer regarding organ donation. Which are the organs that can be utilized if we have given consent earlier, and the forms, whatever it is. I think if you can make a PDF, and we can circulate it to all, because a lot of us are interested. We don't know how to go about. Most
Yes,
of us
madam.
know about eye donation. Even that also, none of us are very serious, and we're not doing it very religiously. So I think for eye donation, you can keep separate PDF, and for other things like
Kidney and
all
liver,
about all about
the organs. Yes,
donation. Yeah.
And one more thing regarding these things, shall we take any consent from the particular government authority to make awareness?
Not for the. I don't think we need to.
Yeah,
This is a thing, no?
it's just awareness, public awareness.
Academic. Yeah. Anyway, I will be also speaking to the. I'll share the numbers, or I'll speak to them, and I'll let you know also. But eye donation, I think we have to seriously make a PDF, and so that we can circulate to everyone.
Yes, madam.
And Dr. Surya Raju, you're there?
Madam, CMA complete ಆಗ್ಬಿಡ್ಲಿ madam ಮಾತಾಡೋಣ.
Yes, yes.
ಹಾ
ಅದೇ,
ಅಲ್ಲ ಸರ್ ಮಾತಾಡ್ತಾ ಇಲ್ವಲ್ಲ ಸುಮ್ನೆ ಬ್ಲಾಂಕ್ ಇದೀವಲ್ಲ
ಇಲ್ಲ ಇಲ್ಲ
ಅದಕ್ಕೆ ಮಾತಾಡ್-
ಈಗ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿದ್ರು ಮೇಡಮ್ ಮಾತಾಡಿ.
ಹಾ ದೆನ್ ವಿ ವಿಲ್ ನಾಟ್.
ನಾರಾಯಣ್ ಸರ್,
ಒಂದೇ ನಿಮಿಷ ಸರ್.
ಎಸ್ ಸರ್. ಅವರು ದೇ ಆರ್ ಎಂಗೇಜ್ ಇನ್
ಈಸ್ ಫಿಗರಿಂಗ್ ಔಟ್.
ಇಲ್ಲ ಇಲ್ಲ ಮ್ಯೂಟ್ ಆಗಿದೆ ಮೇಡಮ್. ಹೇಳ್ತಾ ಇದ್ರಲ್ಲ, ನೀವು ಹೇಳ್ಬಿಡಿ ಮೇಡಮ್. ಡಾಕ್ಟರ್ ಅನುರಾಧ ಮೇಡಮ್.
ಇಲ್ಲ ಇದು he is already put the slide. I think he is unmuted now.
ಮೇಡಮ್, ಅನುರಾಧ ಮೇಡಮ್, ತಾವು ಹೇಳಿದ ಹಾಗೆ ನಾವು ಡೆಫಿನೆಟ್ಲಿ ಆನ್ ದಿ ಬಿಹಾಫ್ ಆಫ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಮಿಟಿ ವಿಲ್ ಮೇಕ್ ಎ ಒನ್ ಪರ್ಟಿಕ್ಯುಲರ್ PDF ಫಾರ್ ಈಚ್, ಲೈಕ್ ಐಸ್ ಅಂಡ್ ಹಾರ್ಟ್, ಕಿಡ್ನಿ, ಲಿವರ್, ಲೈಕ್ ದಟ್.
ನೋ ಎಲ್ಲದಕ್ಕೂ ಬೇಡ ಡಾಕ್ಟ್ರೆ, ಎಲ್ಲ ಓಪನ್ ಮಾಡಕ್ ಕಷ್ಟ ಆಗುತ್ತೆ. ಐ ಡೊನೇಷನ್ಗೆ ಒಂದು ಇದು ಫ್ಯೂ ಸೆಂಟೆನ್ಸಸ್ ಐ ಡೊನೇಷನ್ ಯಾವ ತರ ಮಾಡ್ಬೇಕು, ಆಮೇಲೆ ಫಾರ್ಮ್, ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್, ಅದೊಂದು PDF. ಇನ್ನು ಬೇರೆ ಆರ್ಗನ್ಸ್ ಬಗ್ಗೆ ಒಂದ್ ಪ್ಯಾರಾಗ್ರಾಫ್ ಬರೆದ್ಬಿಟ್ಟು ಏನಾದ್ರು ಅಕಸ್ಮಾತ್ ಫಾರಮ್ಸ್ ಇದ್ರೆ ಅದಕ್ಕೆ ಅಟ್ಯಾಚ್ಮೆಂಟ್ ಹಾಕೋದು. ಬಿಕಾಸ್ ಫಾರ್ ಎವ್ರಿ ಆರ್ಗನ್ ಮೀನ್ಸ್ ಇಟ್ ಬಿಕಮ್ಸ್ ಟು ಇದು ಐಗೆ ಇಟ್ಸ್ ಅ ಪ್ರಯಾರಿಟಿ, isn't it?
ಆಮೇಲೆ ಫಾರ್ಮ್ಯಾಟ್ ವಿಲ್ ಬಿ ಸೇಮ್, ನೋ ಮೇಡಮ್? ಫಾರ್ಮ್ಯಾಟ್ ವಿಲ್ ಬಿ
No,
ಸೇಮ್. ಈಗ
I have no idea. You find out.
ಹೆಲ್ತ್ ಅಂಡ್ ಫ್ಯಾಮಿಲಿ ವೆಲ್ಫೇರ್, ದೇರ್ ಇಸ್ ಜೀವನ ಸಾರ್ಥಕತೆ. ಸೊ that will take care of regarding the format as well as ಅವರು.
For all.
Yes, madam. And also they will take a list also. There is separate system is there. So entirely that will taken care by the department.
Madam?
Yeah.
Yes, sir. Yes, sir. We are ready.
You can go ahead, sir.
Yes, sir. Go ahead, sir.
1 minute, sir. You can hear me, madam, better?
Yes, sir. Please go ahead.
Okay, sorry, madam. Sorry for the interruption. It is right. Okay, madam. You can hear me, madam? No?
Yes, sir.
Oh, okay, sir.
Yes, sir.
Okay, madam. Okay. So, as I told you, madam, this donation and transplant process itself is a complex. It's very difficult for us to handle such a situation. Whereas the potential donor family, they will be in a situation, emotionally disturbed and all. You have to talk with them at their time of tragedy. They are young, near and dear patient have a brain death. So we doctors, it's very difficult for us to go near them, initiate about organ donation and all those things. So, as you know, this identification, the referral of these potential donors usually happens. It should occur at that point, but it is very difficult for us to initiate and talk. So, as I told you, the consequences of a missed early donation and referral, you know that 8 other patients are going to die if you don't convert one patient. The second one is the economic losses to the nation and the state, because a few people will be on dialysis. Many of these patients will be repeatedly getting admitted to the ICU, eating our healthcare resources, and then loss of productivity by all these patients. So these all are the consequences of a missed early donor. So what is the responsibility of a healthcare system? Basically to identify who is the potential donor, who is the donor. So for that we should know the standard definition of the eligibility. And based upon the eligibility, we need to identify potential donor And then once we identify, we need to talk with the transplant coordination team, whether patient is suitable or not, whether it is worth talking to the family, what are the ways where we can facilitate this, how to shift the patient to the higher hospital center, or facilitate the retrieval in that center itself. Is it okay, madam?
Yes, yes, sir.
Okay, sir. Okay.
Yes, sir. Go ahead, sir.
Oh, sir. So, when we were doing our undergraduation and all those things, we used to hear a lot of stories like there is some illegal activities happened in organ donation, some mafia is there, that happens in this government hospital, that happens in Mumbai, somebody go to that, this and all those things were there. Yes, all those things somehow were there at that point of time. So Government of India has noticed this, and they have brought this Women Organ Act in 1994. So what they defined, what the things can be retrievable, they spoke about the organs, solid organs. So where it can be retrievable, only the transplant centers where they have the license to do transplants, only those centers you can retrieve, you have to shift the brain dead patients and retrieve. And then if at all, if it is a living donation, only the close relatives can donate. But the grandparents and the grandparents can't donate their organs to the grandchildren, and the grandchildren can't donate for their grandparents because they are considered as distant relatives. Only the sister can donate to a brother, brother can donate to the sister, and children can donate to their parents. So, and then even the certification, there was a limitation. Only the neurosurgeons, neurologists have to certify who is brain dead, who is not, and then they need to sign and all. So, and then whether the transplantation, we should talk to the family or not and all, they just mentioned about it. So it has been recommended, you need to talk to the family and all. Considering the scale of the problem, what is the how big the problem and all, they brought two more amendments in 2011 and 2014. They clearly defined, in addition to the organs, they added the tissues also, like heart valves, skin, cornea, everything. All is considered as tissues. They included all of them in 2011 and 2014 amendment. They told that the organ retrieval from a brain dead patient can happen not only in the transplant center, but also NTORs, is that is called as a non-transplantable organ retrievable centers, like small-time nursing homes with 2 OTs, 4-5 ICU beds with a ventilator and anesthetists or an intensive to taking care. In even those centers, we can do organ retrieval. So this is the one thing. And then for the living donation, they told that grandchildren can donate to grandparents, grandparents can donate to grandchildren. They told that they are also near relatives, they are not distant relatives at all. So, and then certification of the brain dead patients, they told not only the neurosurgeons, neurologists, surgeons can diagnose, physicians can certify, anesthetists can certify, intensivists can certify. Only thing is they should have the skill, expertise, knowledge of doing the brain stem function tests, and they need to be registered with the competent state government authority. That is the only thing which is required. And then regarding the organ donation, the Government of India made it mandatory for all the hospitals to identify brain death patient, speak to the families that this is one of the options. It's not necessary that all of the families agree and go for organ donation. But from our side, the efforts should not be less. We should identify potential donor, and we need to talk to the families and telling them that this is one of their options. So that is one of the things. And so all those things. Why Government of India is also doing all those things? Recently, we have seen our Prime Minister Narendra Modi, he was talking in on radio, Mann Ki Baat, telling that organ donation we have to encourage and all those things. So the government is going to that extent because the problem is much bigger than what we think about. A lot of doctors, as I told you, they are also on the waiting list. And if we don't do anything, they're going to die. So overall brain dead patients, there is something called as a US criteria, something called as a UK criteria. The US criteria, there is a Harvard criteria. They consider the whole brain death to tell that patient is brain dead. But the UK criteria, they tell only the brainstem death, where the absence of brainstem reflexes are there, which they call it as a brain death. So India follows the UK criteria. But for academic work and all those things, we use something called as a death by neurological criteria to avoid that confusion. So for initiating any organ donation talk, first we need to identify the patient. We need to do brainstem function test. Before doing that, we need to meet the certain set of criteria, like patient should have normothermia, hemodynamically stable. There should not be any metabolic or septic encephalopathy, and then there should not be on any sedatives or anesthetic drugs or muscle relaxants for at least 48 hours or so. And then once the preset conditions are met and there is a neuroradiological evidence supporting the cause of brain death when it is there, then you are going to do certain set of tests which we will call it as a cranial nerve function test, which we are going to do bedside by the qualified doctor. Once he does that, next he do an apnea test to show that there is an absence of the respiratory effort despite high carbon dioxide buildup. So this is which we will call it as an apnea test. So we do these two tests, one set of tests in the after completion of 24 hours, and then after 6 hours from the first test, we are going to repeat the second test of test to tell that patient is brain dead. So once it is confirmed, then we need to talk to the family. So overall, the brain dead patients, what is the source? The patients who are having a severe head injuries following a road traffic accident, it might be an accident, road traffic accident, or domestic fall, industrial accidents, or from heights, construction site accidents, or assaults. So all those patients with severe head injuries can be a potential donors, or as I told you, spontaneous intracranial bleeds like hypertension or aneurysmal bleeds, or large strokes, especially the posterior circulation strokes, and suicidal tendencies, hanging, and all those things. And then hypoxic brain injury following cardiac arrest, toxic injection like a tablet injection, poison injection, all those things. They're all going to have a brain death, and they're all the potential donors. Only thing is we need to identify. If at all, if we have any confusion, if you have a ICU, so how to identify these patients earlier, much before the brain death. So most common elements in identification, these patients will be on mechanical ventilation. They might be having a low GCS. They might be having a history of devastating brain injury, like a road traffic accident or a stroke or a bleed or something will be there. And where the team is talking about end of life care. So ಇವ್ರ ಕಂಡೀಷನ್ ಚೆನ್ನಾಗಿಲ್ಲ, ಮಾಡೋದೆಲ್ಲ ಮಾಡಿಬಿಟ್ಟಿದ್ವಿ, ಮನೆಗೆ ಏನಾದ್ರು ಕರ್ಕೊಂಡು ಹೋಗೋದಿದ್ರೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಬಿಡಿ, ಇನ್ನೇನು ಮಾಡಕ್ಕೆ ಚಾನ್ಸಸ್ ಇಲ್ಲ. ನೋ ಅದರ್ ಆಪ್ಷನ್ ಇಸ್ ದೇರ್ ಟು ಟ್ರೀಟ್ ಹಿಮ್ ಫರ್ದರ್. So when while discussion is happening, all this patient might be brain dead patients, and they might be potential brain dead patients also. Okay, they are the potential donors. So these are the patients we should look for. So to make it more simple, we use the acronym Q. That means what? GCS less than 5, intubated, patients will be on a ventilator, and having a poor prognosis, which we have already spoken to the family, and you have initiated the end of life care. So these are all, when we brain dead patients, they are all possible potential donors. So definitions: possible donor, a patient with a brain injury or a lesion having a GCS less than 5, and they meet the set of conditions. When these patients GCS drops to 3 and all, and they meet the criteria of brain death, that is absence of cranial reflexes, and then apnea test, is positive, they are the potential donor. They become eligible only if there is a medical suitability is there, and also there is no contraindication, and the family agrees and give a consent. They become the eligible donor. And the actual donor is the one where the patient eligible donor has been prepared and shifted to the OT, and then a surgical incision has been made to retrieve an organ. Whether it is on table suitable or not, that is a different matter. But when there's surgical incision has been made on the table with an intention to retrieve an organ, that patient is called as an actual donor. So, what are the contraindications? So, when I go to the field meeting, all the important doctors like you and all, they will ask me, ಯಾವ ತರ patients brain dead ಆಗ್ಬೋದು? What are the contraindications? Which are all not, which can't be considered. So, I tell them that having a severe intracellular infections like Listeria, Trypanosoma pallidum, or where the infection is there, you don't know what is the type of infection, patient is in septic shock, requiring multiple vasopressors, or having a brain infections like uncertain encephalitis of viral origin, like brain encephalitis and all those things. Basically, the brain infections, or even TB meningitis, or acute fungal infections, or an opportunistic infections, retropositive status, that is HIV positive patients, and medical conditions where there is no known medical treatment. Like, for example, dengue shock syndrome. You don't have a definitive treatment for a dengue shock syndrome, just a supportive care like IV fluids, organ supports, and all those things. Same thing with respect to rabies and all. All these patients are not potential donors at all. And also, patients having a metastatic malignant neoplasm, acute leukemia is there. That is the blood cancer and all those things. And then acute lymphoma, melanoma with less than 5 years follow-up, multiple myeloma. These are all contraindications. Am I okay, sir? You can hear me?
Yes, sir. Go ahead, sir.
Sir.
Yes, sir.
You're okay, sir? You can.
Yes, sir.
Yes, sir.
You
Please
can hear
continue.
me, no?
Yes, sir.
Yes,
We
sir. Yes,
can.
sir. We can listen to you, sir. Please go ahead.
Okay, sir. So, all of us, that is the healthcare personnel, involved in the end of life care discussion, should identify the potential donors out of those patients where you know that you have given the best possible treatment, where there is no other chance of survival of such patient. You should always see through whether they are the potential donors. They might be potential donors. Say, for example, one young patient, road traffic accident, severe head injury, Jesus is very poor. So, and then family, ಇನ್ನೇನು ಆಗಲ್ಲ ಡಾಕ್ಟ್ರೆ, ಅವ್ರೇನು ಹೋಗೋನಿಂದ ಹೊರಗಡೆ ಬರಲ್ವಾ, ಚೆನ್ನಾಗಿಲ್ವಾ, ಮನೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಬೋದಾ? You will be the potential donor. Only the brain is taken the hit, is brain dead, but all other organs are functioning. So 8 other people can live from him. So you can always tell the family that your patient is not going to live in that body, but he is going to live in 8 other bodies. So this is all who should talk. The most responsible physician in the team. Not everybody should speak. Only one senior most physician, after talking with the entire team of consultants. So what should we talk, and who has to talk, what needs to be spoken, when we will talk, all those things. So the physician need to be designated, and he should talk to the family, and at the same time raise the referral to the transplant coordination team to clear their doubts. So this is one of the things. Whenever something happens to the patient, injury, when there are chances of recovery, then we will actually treat them. When there is a poor prognosis, then we will think and talk with the family about withdrawal of the life support, withdrawal of the life support treatment and all. So at that point of time, as I told you earlier, we have to find out the potential donor and then talk to the family, talk to the transplant team also, take a consent for organ donation. Then once the consent is taken, maintain the potential cadaver with the proper donor management. And when the retrieval team comes, they will do the organ retrieval and the donation happens. So if you see in the whole population, today you might be thinking like, ಈ ಡಾಕ್ಟರ್ಸ್ ತುಂಬಾ ಮಾತಾಡ್ತಿದ್ದಾರೆ, ಅಷ್ಟೊಂದು ಇರುತ್ತಾ ಇಲ್ಲ, ಹೆಂಗೆ ಐಡೆಂಟಿಫೈ ಮಾಡೋದು? ನಿಜವಾಗ್ಲೂ 150,000 ಪೇಷಂಟ್ಸ್ ಇಂತಹ ಬ್ರೆಂಡ್ ಇರ್ತಾರ ಇಂಡಿಯಾದಲ್ಲಿ? To make it understand you simpler, I will tell you, you have to take the total population, number of deaths which are happening in the population. Out of that, you have to see how many hospital deaths are happening. In the hospital, how many deaths have happened while being on ventilator, and ventilated patients, how many had a severe brain injury, like following a road traffic accident or following an intracranial bleed or a hanging and all those things. So among them, how many are the potential donors? Potential donors, how many have been referred by speaking to the transplant team? And then how many are the eligible donors? That is, the eligible donors are the one, as I told you, there should be medically suitable. There should not be any contraindication, and the family should have consented. Then those patients, consented donors, once they are consented, they become the actual donors, and then they are the utilized donors. So if you see, this is the inverted pyramid. Deaths are so many, brain deaths are maybe so many, but see the utilized organs. So not much. Okay, this is the Canadian inverted pyramid of organ donation. So if at all, if we do all those things, if we participate in discussion, what are the advantages? We will get additional knowledge, which case can be taken, which case can't be taken, whether your patient is suitable or not, what are the contraindications, if at all the retrieval has to happen, where it should happen, who is going to come, how we have to plan, all those things, and also clarifies the donor eligibility, and will help you in early planning and preparation for arranging logistics. And then if you want the help, if you talk to the transplant team by giving an early referral, one site coordinator can come and help you out with the planning and all those things. They will also come and help you by engaging the staff and the family early on, so that the family can also give consent by having confidence in the entire team and all. And then it normalizes the integration of end of life counseling with the organ donation, and then gives sufficient time for the transplant team to travel to the hospital. So some patient will be there waiting in Hyderabad for a lung donation. If such a brain dead patient is there in Bijapur or even Raichur and all those things, they require certain time to reach that place by arranging the logistics, because the cold ischemic time might be around 3 hours, 4 hours and all. This is the time, nothing but from the time of retrieval to the transplant in the potential recipient. So this time also need to take into account the traveling time also. So if you talk to them much earlier, it can they can come much early and then do that. If at all, if you don't do that, and if you take a longer time for identifying and giving a referral, longer waiting for time will increase the risk factor for cardiac arrest and consequent loss of potential available organs. So as I told you, all those patients are going to die. Simply, if you lose one, if you don't identify and give a referral, so many patients are going to die. So that is a missed opportunity. And then sometimes you may have a patient, their creatinine might be high, age may be around 60 years. Question comes whether the kidney can be taken. So there is something called as the standard criteria, which is the ideal criteria, which we all know that patient potential donor should be young. You should have a healthy kidneys. His creatinine should be less than 0.8, both functioning kidneys. Then we will tell that is the ideal guy, meets the standard criteria, nothing better than that and all. Because the availability of the organs is much, much less, and the list is much more, waiting list much higher, waiting list much, much bigger. So the medical fraternity, they also made that an extended criteria to increase the pool of organs available. They told not only 30 years and all, even up to 60 years also we can consider, even if the patient is having hypertension, cerebrovascular accident is also there, which is the cause of brain death, and the creatinine is slightly higher, is still okay. We can take a call, come and see, do an ultrasound, see the corticomedullary differentiation of the kidneys, whether it is good or not, and then we can take a call. So he can also be a potential donor. Sometimes I receive a call about an elderly patient, whether he's a potential donor. Family Matatidar, sir, they are interested in donation, not only corneas, they want to give each and every organ, they want to donate and all. So when I receive such a call, I can always tell that I can't reject such a patient. He might be a potential patient. We have to respect the sentiments of the family. Age is not a criteria for the liver, at least, because liver function may still be good even in elderly patients up to 70-75 years. You can still donate liver, but the heart and lungs can be donatable only up to 45 years. Kidneys can be donatable up to 60 years, 65 years. There is no contraindication. For liver, there is no upper age limit for the donor. For example, serology is positive. What should we do? As I told you, retropositive patients are contraindicated. HCV positive patients, they can go to a HCV positive recipient. So that is still okay. And then hepatitis B, if there is no active infection, they can be and the viral load is much less. They can be on a patient who is hepatitis B positive on medication. He can be a potential recipient. Heart, as I told you, it should be ideally between 31 to 40 years, but it can be extended up to 50-55 years also. Ideally, it should be, weight is also one of the important thing. The donor weight should be 20 to 30% of the recipient. So that basically, because heart is like a pump, it need to cover the extra weight, extra tissues and all those things. So this can take care of 20 to 30%, either more body weight or underweight of the recipient. That is accepted as per the standard criteria. And then diabetes and hypertension. Metabolic disorders, they are there. We need to be very careful because atherosclerosis is much more common. He may be having heart blocks and all. His heart may not be taken. That also we need to keep in mind. If at all, if the patient is having long-standing hypertension, LV hypertrophy will be there. LV wall thickness more than 1.4. So this may not be considered. But the new criteria, because lot of patients are there in the waiting list for the heart also, the criteria has been expanded. This is the expanded criteria. Age up to 65 years, size 20% more or less than body weight, prolonged hospitalization, even if the patient has met with an accident having a chest trauma, his troponin is very high, still can be considered. Echo is not looking normal, having a wall motion abnormalities on the echo. Hold ischemic time 4 to 5 hours, still okay. Long distance procurement still happening. They are coming by helicopter, air ambulances and all. They are retrieving. Even if the patient is in cardiogenic shock, high vasopressor requirement, still we can't rule it out. And correctable valvular dysfunction, if it is there, identified by echocardiography. Even if the patient is having a coronary artery disease, 1 or 2 vessel coronary artery blocks are there, still he can be a potential donor. We can do angioplasty and take that heart. And prolonged CPR time. If the patient have a cardiac arrest, more than 5 minutes revival after doing CPR, patient is revived. He can also be taken. He can also be a potential heart donor. Lungs, ideally it should be less than 55 years. ABO compatibility should be there. Chest X-ray should be good. His ventilator requirements, ventilator setting should be good oxygenation and all. Less than or equal to 20 pack years of smoking should be there. If at all, if he's a smoker, and then absence of chest trauma, there should not be any prior surgery. The patient in the state of low GCS, he should not have vomited or aspirated, or lung infection is there. Absence of purulent secretions, if you do a bronchoscopy from the lung. it should not be there. This is the ideal criteria. But the extended criteria, they tell even if the patient is having mild asthma, age more than 55 years, even if a moderate ventilatory setting requirements are there, and even if the smoker more than 20 years, we need to do a good evaluation of the lung and still can be considered. And then, but certainly absence of lung disease should be there. As you know, a lot of diabetic patients may have uncontrolled sugar. They may have a kidney dysfunction might be there. We see a lot in Bangalore. We see a lot of patients undergoing kidney and pancreas transplant together. So this is one of the answer for a uncontrolled sugars following diabetes. So they can be a potential recipient for the pancreas. So pancreas also up to 45 years we can take. Intestine, somebody having a end stage intestinal dysfunction can be taken. The potential donor should be less than 50 years. There should not be a blunt injury abdomen like a following a road traffic accident, blunt injury abdomen. It should not be there. There should not be intestinal injury. ICU stay less than 1 week. And then sodium level, this point is important. All potential donors, you have to maintain potassium levels between 135 to 140, 145 and all. Higher sodium levels are not good for any organ function. Organs will not be that feasible even if the family give consent. So maintaining the sodium levels is one of the important thing, and also evaluation of the bone length and functioning by CT enteropathy. We need to do all this workup before we consider for any intestinal donation. So I'm coming to my end of my talk actually. If I don't do all these things, you still have doubts, but you are not called any known referral team, you are not identified, you allowed the family to go home, Dama, ಅವರು ಹೋಗ್ಬಿಟ್ರು ರಾತ್ರಿ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಸಾಯ್ತಿದ್ದಾರೆ, ನಿಮ್ಮನ್ನ ಕರೆಯೋಣ ಅಂತಿದ್ದೆ, ಅದು ಆಗಲಿಲ್ಲ. If that all happens, it will be a huge loss to the society. One of the loss to the potential donor family is not respecting to the wishes of the potential donor, who during his lifetime, who should have gone to Jiva Sarthakate, got his organs registered, pledged, he should have registered and all. He should have informed his family also his desire to donate. But at that point of time, you're not told the family that your patient is brain dead. This is one of the options which is available. And all. If you're not told, if the family is a bit illiterate, because you have not told them, they should not have, because without their knowledge, they can't give. You have to go and tell that your patient is brain dead. And then if they ask what are the options available, you can tell that because he is brain dead, this is also one of the option of organ donation. Okay, that is the legal right, which Government of India told that this is the legally the right of the family of the potential donor. They have the right to know. Only thing is we have to open our mouth, see the appropriateness of the situation, talk to the family and tell them. Not providing the family, if you don't convert the patient for organ donation, that means that that family has lost an opportunity to leave a legacy in the society. If at all, if some donation happens, it will come in state papers, all India papers, English, Kannada, and all those things. A lot of people will read, and then they will tell, ಇಂತಿಂತ ಮನೆಯವರು ಈ ತರ ಮಾಡಿದ್ದಾರೆ, ಒಳ್ಳೆ ಕೆಲಸ ಮಾಡಿದ್ದಾರೆ, ಅಂಗದಾನ ಮಾಡಿದ್ದಾರೆ. So that makes the family proud in the society. So it's an opportunity for them to leave a legacy. If you don't do, you are going to deny the family of leaving a legacy. That is one of the thing. And then if a donation doesn't happen, death of a recipient or a disability of the potential patient, and also economic cost to the community with the patient having patients with end organ disease. And then economic productivity will also be lost because they are not going to work. There won't be any productivity from their side. And then if nothing happens, you as a medical fraternity, you are losing an opportunity to pass an information to the society. Whenever I go and meet doctors, they will tell, awareness create madbek sir, hage hege. We do a lot of talks, public meetings. We go through IMA talk to the family, talk to the doctors, so that they can take home the message and spread to the society. We do engage with NGOs like Rotary Club, Lions Club, and all those things. And then Infosys Foundation, go to the society. We do awareness program among the public. But that all we are going to do. But at the same time, one single act of donation from one of the brain death patient will come in the newspaper. That through that we can pass on the message to the society that you, by doing so, you can save so many patients. If you don't do identify and correct time, you don't identify and referral, you're going to simply lose the opportunity of all these things. So I am coming to the end of my talk now. Thank you, sir.
Thank you, sir. It was a wonderful information that you've given. So, any doubts or anything, we will take up now.
Something is there in the chat box, madam. You can read me those questions.
Yeah. No questions, as such, sir.
Okay, sir. Okay, sir.
But
Sir,
Dr.
sir, any broad death patients, how to handle, sir? How would we convince, sir? How could?
Sir, any broad death patient is not a potential donor, sir. I want to make it clear, sir. Any broad death patient where the heart has stopped, there is no pulse, there is no ECG activity, is only a donor for the cornea. But the corneal donation is there, sir. A lot of people they are doing. What the major problem as of now is a solid organ donation, which can only be done from a brain dead patient, sir. Somebody like a patient having intracranial bleed following a road traffic accident, major hypertensive bleeds, or hanging, partial hanging, where the heart is still functioning, ECG is recordable, and then whom you are going to put the patient on ventilator. But there won't be any brainstem reflexes. Only those such patients are the potential donors, sir.
Okay. And in smaller setups, how could we retrieve the organs and send it to the bigger setups?
Sir, that you need to talk to an organization called as a Jiva Sarthakate, sir. That will be there in each and every district. That is one of the wing of Health and Family Welfare, Government of Karnataka.
Yes, sir.
So if you activate that, one of their representative will come. They will ask you to get few investigations done. Those investigations, they will check out whether the organs are okay, suitable or not. Once the organs are suitable, they will activate the potential hospitals where the recipients are registered to come and retrieve the organs. If at all, if it happens in a smaller hospital. My point is this, sir, because it happens in a remote place from where heart and lungs are not regularly transplanted even in big cities, sir. Like Hubli, Belgaum, all those things. It has to come to bigger cities like Bangalore, Chennai, Hyderabad, and all those things. So when such things need to happen, my advice is better to shift such a brain dead patient to a bigger hospital where they have all the licenses, where all the organs can be donatable in the next OT, or if there is no potential recipient from there, because of the good connectivity, transport connectivity, he can go within 1 or 2 hours to the neighboring cities also, like Hyderabad, Chennai, Pune, Mumbai, and all those places, sir, by air ambulances or anything like that.
Is any written consent required from the patient attendant, sir?
Definitely, sir. For organ retrieval, we require a consent from a blood relative. For example, if the husband is a brain dead patient, if he is married, we have to get a consent from the wife. That is important. If he is having a living parents or living children, we need to get a consent from them. And if he is unmarried, if he doesn't have parents and all, his sisters, brothers, they can give the consent, sir. So consent from the blood relatives is more important, sir. Or,
Thank you, sir.
sir,
Yeah.
sometimes we can have a brain dead patient who is an orphan, mother and father is not there, no sister, brother, not married and all. But some uncles like Dodappa, Chikkappa, they should have they should have been the guardians and all. You have to, in such cases, you have to give the death certificate of the parents and then tell that he is the guardian, he can give the consent. So that can also be done, sir. We have done in few of the cases.
Thank you, sir. Thank you.
We have one question, sir, in the chat box.
Tell me, sir.
Whom to contact or which center to contact in Bangalore for organ retrieval?
Sir. Sir, that's what, sir. What we can do is, as I told you, sir, there is something called as a Jiva Sarthakate, that is, which we will call it as SOTO, that is a state organ tissue transplant organization, which is there each and every district, sir. In Bangalore also, we have one office in Arogya Sauda, which is on the Mahagadi Road, sir. I think so.
Yes.
So we have to call them. They will come and collect all the reports, find the medical suitability. If the patient is suitable, then they will talk to the family and get the things done. Otherwise, what as earlier we used to do, like private institutions, we are also there. We can also pitch in. We can come and see the patient. If we think that he is medically suitable, we will shift the patient to our respective hospitals to further suitability testing, activate Government of Karnataka Jiva Sarthakate. They will come to our hospitals. They will see all these things and all. They will go through the waiting list, which is there with them already, who has been registered with Government of Karnataka. They will see who is the potential nearest relative, nearest good recipient, and then they will allocate the organs. So the retrieval will happen in these hospitals and go to the allotted hospitals where the allotted patients will be there, waiting there. Sometimes there may be super urgency list will also be there. Some patients, if we don't receive an organ, is going to die within next 24 to 36 hours. They will put it in some of the hospital super urgency list. Means he will bypass all the waiting list and will be on the top in the waiting list. If such a thing is there, if we find a suitable donor, he will get the first preference, and that will be decided by Government of Karnataka.
Thank you, sir. Sir, in your routine, last 30 years here, you are into this field. What are the challenges you are coming across when you go for, the organ donation? What are the challenges, sir, you are facing in general?
Sir, I have worked in Manipal Hospital earlier. When I started my career, this was 25 years back. Then I was in a Narayana Hrudayalaya for 12 years. Then I was in Aster CMI for 4 years. Then I am with Manipal Hospital back now. So all this while I was working with in intensive care, I have seen some of the brain dead patients who are admitted there. When I was younger, I don't know how to reach them, how to talk to them about organ donation, how to initiate the conversation, all those things were there. On the other side, I've seen a lot of patients dying with heart failures, kidney failures, liver failures. A lot of patients, they used to die and all those things. So now, with all the gained experience, we are not only looking inside within our chain, we are also coming outside, reaching you people and all. Even if one patient is there, we are coming there. The challenges, coming to your direct question, sir, the challenge is when to talk to the family. That is the thing. What we understood is, with our experience, if the first is the family should understand that their near and dear is brain dead, first one. If they have not understood and not accepted brain death, there is no point in talking about organ donation. If you talk organ donation before the family have accepted, understood the organ, the brain death, it will be futile. So you have to talk only when they have accepted that their patient is brain dead. And then the person who has spoken and declared the patient is brain dead should not give that option of organ donation. He should not talk. Somebody else should come and talk. Once you tell the family that your patient is brain dead and then maintain a long pause, then they definitely ask you what to do, sir. Yen madodu. Next yen madodu. You have to wait for the family prompts. Like they will ask you, yen madodu, sir. Next yen madodu, sir. Helbidi, sir. Nivu. When they ask you, at that point, then you can gently tell that you have that golden option of organ donation. And then just stop at that. When the family, if they express the interest, when they tell, sir, adu hege, sir, process hege, then you can tell that there is one transplant team, coordination team is there. I'll call them. Everything goes through Government of Karnataka. That means what? It is transparent process. There won't be any illegal activities which will be going on. And whenever organ retrieval, usually the common doubts with the family have is, the first one is whether is it transparent, the process is transparent or not, whether it goes through the government scrutiny or not. The third one is during the process of organ retrieval, whether the body will get disfigured, whether once the organ is retrieved, whether the handle will give respect to that body, donated body. All those things will be there. So if you tell them the entire process of organ donation, that how it happens, how the organ retrieval, how the organs are allotted, and all those things, and then you have to tell them that organ retrieval, only one surgical incision like our large laparotomy incision will be there, which will be under the dressing, which can't be seen outside. There is no disfigurement. And all, when you tell them all these things, usually they will agree. And then once you tell all these things, and then you should not push through. ಏನು ಡಿಸೈಡ್ ಮಾಡಿದ್ರಿ, should not tell them. Just tell them, ನೀವು ಡಿಸೈಡ್ ಮಾಡ್ಕೊಳ್ಳಿ, take your own time. I will be available here in my chamber, ground floor, first room. I will be there. After you decide, you can come to me and leave that private room to them and come outside. And you should not go back and knock their door. ಏನು ಡಿಸೈಡ್ ಮಾಡಿದ್ರಾ? You should not do. Just leave them there. They will only come and tell that, sir, ನಾವು ಡಿಸೈಡ್ ಮಾಡಿದ್ದೀವಿ ಸರ್, ನೀವು ಹೇಳಿದ್ರಲ್ಲಿ ನಂಬಿಕೆ ಇದೆ, ನಾವು ಮಾಡ್ತೀವಿ, ಅವ್ರು ಯಾರಿದ್ದಾರೋ ಕರೆಸಿ ಸರ್, ನಾವು ರೆಡಿ ಇದ್ದೀವಿ ಸರ್. So in this way, we have seen at least 90% of conversions happening. And then to make it much more easier, Manipal Hospital, they put some people, compassionate people like some passionate people like me and all, to go reach to the respective hospital. They have given us their infrastructure, vehicles and all. So we will reach out to the whatever hospital is there, check the medical suitability. We will talk with the transplant teams whether this is a suitable donor or not. Then understand the family equation and talk appropriately, and we will facilitate the organ donation consent.
Sir, I would like to speak.
Tell me, madam.
Sir, in spite of being in this profession,
Okay, madam.
almost all of us are not aware of how best we could utilize our knowledge. So
Okay,
coming
madam.
back, don't you think, sir, any hospital which has ICU facility needs to put a board outside speaking about these two things? Have you signed, given your consent for eye donation? Not outside ICU, in that hospital premises. At least I'm going to tell my hospital director to put this banner and also speak to the FANA, etc., etc. So if you put outside near the reception, you have option of eye donation, you have option of organ donation. Touch wood, we don't know who's going to land up with who in the family could go brain dead, isn't it, sir? So
Correct, madam.
awareness needs to be created for the public, before the public, you and me as medical professionals, we are going to see the board and we are going to realize that it's our prime duty to speak about it to our people. So whenever you refer a patient who is very serious, then as a referral doctor, we will also put in a word about this. As a referring doctor, you will have they will listen to you about organ donation rather than a stranger ICU doctor speaking to you about it. That's what I feel. And I think at your level, you're all doing your best, sir. But I think all of us have to put in hands to get better results. So I think Dr. Surya Raju, you have very good decision to get sir to talk to all of us. And I think we will see to it that we all put boards outside, even in our own clinics also, anywhere. I think we should put banner regarding organ donation, one. And the other question I wanted to ask you is, suppose a family decides for organ donation, brain dead patient in the family, what would be the approximate time that they have to wait for the body to be given to them?
Madam,
Approximately.
madam. So for the if organ retrieval happens in your hospital, means that your hospital have 2 OTs, you have a ICU with ventilator, all those things and all. If it comes as per the definition of the non-transplantable organ retrieval center, NTORC, if it comes to that, we can retrieve from there itself and given the body there itself.
As
From
early
there,
as
as early as possible. But there is a other way. If at all, if you want the better graft survival, means see as per what we see, graft survival. Basically, the person who has received a graft, the best possible. If you create a best possible environment, and the transplant is also happens in an ideal environment. If at all, if it happens, the best lifespan is another 15 years for such patients. 15 years, additional 15 years for that organ to survive in such a patient. If that has to happen, it has to be happen in a hospital where you have multi-organ license. It will happen next OT, so that the cold ischemia time or warm ischemic time, whatever is there, is very short, within few minutes. Here we are going to take next OT, we are going to walk in and do the grafting. So these two things are there. If at all, if you come to the bigger hospital, there they need to wait for 48 hours. If they come to, for example, if they come to a bigger hospital like a Manipal, Apollo, or any other hospital, if initially he was admitted there and subsequently come over there, so for a bigger hospital, they need to wait for another 48 hours. Why this 48 hours? 48 hours to activate the government of Karnataka, and then they will need some time to identify the potential recipients. Recipients might be far off. They should have been out of that place. They should have been around 400, 500 kilometers away. They need some time to come here. They need to get their tests done. They need to be. They need to undergo one more session of dialysis so that they can have the ideal environment, best chances of success. So they need to get prepared. So they require that 48 hours. So that is what usually is there, sir. There, madam.
Thank you, sir. One more thing, what I observed, sir, the complexity of the organ donation and transplant in India, because of many factors. One is legal issues, government related issues, patient attenders not accepting to donate, even though they are aware about the brain dead, because of the socio-economic, religious factors and family cultural issues and sentiments, sir, family sentiment. These are one of the major hurdles for the organ donation and challenges, which even though many centers are interested to go for the transplant, there are many challenges. They will ask, what are the results? What is the cost? And after transplant, you'll be all right. Then every month, what will be the cost incurred? So this is my opinion, sir. Renal transplants. So these are the challenges. This is the reason why we are, even though we are world class health centers are there in India, and
Okay.
we are attracting medical tourism, and still organ donation and transplant, we are in the very, very basic level, sir. Is my
Sir. Correct, sir. Correct, sir. Definitely, sir. When we go there, we will have, we will face a lot of challenges there, sir. First of all, the family may not agree. No, second one, they will think about what will be the cost. We have to incur the cost, the ambulance cost, their admission, all those things. Already we have lost so much of money for the primary care and all. Third one, religious sentiments, definitely they are there. Um, so all these things they are there, sir. Individually, if you see, sir, uh, if at all, if somebody decides to donate, if at all somebody decide to donate, it will be free of cost to facilitate such a uh, 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 generous uh, act, sir. Actually, if they take such a decision of donating their near and dear's organs, it is a zero billing admission anywhere. That is clearly defined, if at all. That is the first one. The second one is the religion. Religion is a bit difficult because the religious leaders are involved, all those things. Even if we can convince the family, the religious leaders, the influencers, they can come and play the spoil sport. That is there, definitely. Very difficult to handle. Economic status, not much, sir. If somebody want to donate, they may be well-to-do in the society. They want to leave a legacy. They can do that. Somebody who don't have money, but they want to donate, it will be done free of cost. Government has clearly told that it will be free of cost once they decide about organ donation, as per Government of India. Anywhere throughout the India, any state, Karnataka, Andhra, Telangana, wherever it is. So, but the thing what I have seen is, sir, I actually, we in Manipal, we have done quite few transplants. I am proud to tell that even one of the doctor, when she had a brainstem death while traveling, road traffic accident, she being around a young doctor, 24, 25 years, she family has donated her organs. She is living in 8 other people. One young guy around 19 years old, only son of the family. Mother is a widow. She being uneducated, she actually given a consent for organ donation. We see a lot of stories. But the recipient side also, where we have some we have some happiness to tell before you is we have one recently one national level athlete, a gold winner for the nation or for our state. She had a pregnancy. After delivery she had heart dysfunction, peripartum cardiomyopathy, requiring ECMO support and all. She was on ECMO to support the heart for nearly 1 month. It's very difficult for us to arrange a heart for her. She required a heart transplant. Somehow, in the government pool, we got a heart because we have put her on the super emergency list and all. She got the heart, and we could able to successfully get the heart transplanted on her. She is fit and fine now, undergoing cardiac rehabilitation. So we are proud about few things like this, small thing like this. We had one other patient had some emergency following a living donation to her mother-in-law, some daughter-in-law donating to the mother-in-law and all. Following donation in one of the major hospitals, it happened, and then she was in on her deathbed actually. So I had one patient who where the family was willing to donate. That lady was around 35 years, but our donor was 65 years. They could not find any suitable liver at all. So our family was ready to spare their relatives' liver to that young lady so that she can have life once again. But before we could facilitate, unfortunately, that patient has died. She was a associate professor, economics, She has a small child. So all that stories are there. But what I see, sir, what pains me a lot is we in our hospitals, we knowingly or unknowingly, when we are there or when we are not there, night admissions, these such patients should have come to our ER. They should have got admitted to the ICU. Our junior doctors should have seen. They should have some idea that this patient is brain dead probably and all. They should not, or they should have doubts. They should not have clarified with any one of us, and they should have uh, n- uh, they should have just left the patient away. Usually, these sort of patients, they will push to one corner of the ICU. Nobody attends the brain dead between and bidi, and they will take care of the other patients, and then that patient is going to die. What we do, we get that patient to the center of our ICU. We in addition to one sister, we will put 2 additional sisters. Totally 3 sisters. Nursing staff will be working on that patient. We will go and see what is sodium, what is the electrolytes, what is the urine output, what is the blood pressure. We will put additionally 1 consultant intensivist for that patient alone, because that patient is equivalent to 8 other living patients. We do the entirely opposite thing. So whenever I go and meet some doctors, they will tell, last week ittri ಒಂದು patient ಇತ್ತು, ಯಾರಿಗೆ ಬಂದಿತ್ತು, ನಾವು ಅಲ್ಲಿ ಇರೋ ಅಂತಂದಿದ್ದಿಲ್ಲ, ಅವ್ರು ಹೋಗ್ಬಿಟ್ರು, ನಾವು ಅಲ್ಲಿ ಮಾತಾಡೋಕೆ ಹೋದ್ವಿ, ಹೀಗೆ. So these are all lost opportunities. Today also I heard a lot from the referral doctors that last week ಇತ್ತು ಸರ್, ಒಂದು patient ಬಂದಿತ್ತು, ನಿಮ್ಗೆ ಹೇಳೋದು ಮರ್ತು ಬಿಟ್ಟೆ. That is a lost opportunity. Somebody's life. That's how it is, sir.
Thank you, sir. Actually, ತುಂಬಾ ಚೆನ್ನಾಗಿ ಹೇಳಿದ್ರಿ ಸರ್. ಆಕ್ಚುಲಿ there is requirement of 2.5 lakhs. ನಮ್ಮ ಇಂಡಿಯಾದಲ್ಲಿ ಈಗ 1.5 lakhs ಆರ್ಗನ್ ಡೊನೇಷನ್ ಸಿಗ್ತಾ ಇದೆ, ಬಟ್ ನಮ್ಮಲ್ಲಿ ಆಗ್ತಿರೋದು ಲೆಸ್ ದೆನ್ 1000.
ಐಡೆಂಟಿಫೈ ಮಾಡ್ತಾ ಇಲ್ಲ ಸರ್. ಐಡೆಂಟಿಫೈ ಮಾಡಿದ್ರೆ ನಾಳೆ ಹೇಳೋಣ ಅಂತ ಬರುತ್ತೆ. ಇವತ್ತು ರಾತ್ರಿ ಆಗ್ಬಿಟ್ಟಿದೆ, ಅವ್ರು ಯಾರೋ ಮಾಮ ಬಂದಿಲ್ಲ, ಇವ್ರು ಬಂದಿಲ್ಲ, ಬೆಳಗ್ಗೆನೇ ಹೇಳ್ಬಿಡೋಣ ಅಂತ ನಾವು ಮನೆಗೆ ಹೋಗ್ಬಿಡ್ತೀವಿ ಸರ್. ರಾತ್ರಿ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಆಗ್ಬಿಟ್ಟಿರುತ್ತೆ ಸರ್. So we work from Manipal Hospital, sir, 24/7. If any patient is there anywhere, I'm just a call away. ರಾತ್ರಿ 12, 1 o'clock ಆದರೂ ನಾನು ಬರ್ತೀನಿ ಸರ್ ಮಣಿಪಾಲ್ ಹಾಸ್ಪಿಟಲ್ ನಿಂದ. ಇಟ್ ಈಸ್ ಲೈಫ್ ಈಸ್ ಆನ್ ಅಂದಂಗೆ ವಿ ವಿಲ್ ಬಿ ದೇರ್.
ಇಮೇಲ್ ಫೋನ್ ನಂಬರ್
ಮೇಡಮ್ ನಾನು ಹೇಳ್ತೀನಿ ಮೇಡಮ್. ಸಾರನಾಥ್ನು ಇದೆ, ನನ್ನ ನಂಬರ್ ಹೇಳ್ತೀನಿ ಮೇಡಮ್.
ಇಮೇಲ್ ಕೂಡ ಕಳಿಸಿ ಸರ್.
ಮೇಡಮ್ ನನ್ನ ಇಮೇಲ್ ಮೇಡಮ್, ಫಸ್ಟ್ ಫೋನ್ ನಂಬರ್ ಹೇಳ್ತೀನಿ ಮೇಡಮ್.
ಎಸ್ ಸರ್.
98456
98456
194 28.
ಓಕೆ ಸರ್. ಇಮೇಲ್
ಮೇಡಮ್ ನಾರಾಯಣ್ NARAYAN MWOLA ಮೂಲ @gmail.com ಮೇಡಮ್.
Yes, sir. We are going to circulate it in our and your this thing, sir, designation.
Madam, ನಾನು senior consultant critical care, madam.
Yes.
Manipal Hospitals ಅಲ್ಲಿ. I work for Manipal Hospital, Old Airport Road, Manipal Hospital, Yeshwantpur, and Manipal Hospital, Sarjapur Road. So ಹೀಗೆ madam. So I am a group resource, madam, Manipal Hospital ಅಲ್ಲಿ. ನನಗೆ
the efforts, so the efforts from the donor side is humongous, sir. The recipient circle, they are already aware. They are on their war foot to get the donor. But for the donation, sir, there is lot of work, and I think a lot of counseling has to go on from all of us.
Madam, ನಾವು ಅದನ್ನ ಮಾಡ್ತೀವಿ ಮೇಡಮ್.
ಅಲ್ಲ ಸರ್, ನಾವು ನಿಮ್ಮವರೆಗೂ ಕೊಡ್ಬೇಕಲ್ಲ.
ಅದೇ ಮೇಡಮ್, ನಾವು ಬರ್ತೀವಿ ಮೇಡಮ್. ನಾವು ಹೇಗೆ ಮಾಡಬೇಕು, ಮಾತಾಡ್ಬೇಕು ಅನ್ನೋದನ್ನ ಹೇಳ್ತೀವಿ ಮೇಡಮ್.
ಇವತ್ತು ಹೇಳ್ಕೊಟ್ರೆ ನಾವು ಉಪಯೋಗಿಸ್ಕೋತೀವಿ.
ಶೂರ್ ಮೇಡಮ್, ನಾವು ನಿಮ್ಗೆ ಟಚ್ ಅಲ್ಲಿ ಇರ್ತೀವಿ. ನಿಮಗೆ ಲಾಜಿಸ್ಟಿಕ್ಸ್ ಏನಿದ್ರು ಸಹಿತ ನಾವು ಎಲ್ಲ ಬಂದು ಫೆಸಿಲಿಟೇಟ್ ಮಾಡ್ಬೋದು ಮೇಡಮ್. ಇಟ್ ಈಸ್ ಫಾರ್ ಎ ಲಾರ್ಜ್ ಮೀನ್ಸ್ ಎ ಗ್ರೇಟರ್ ಸೋಷಿಯಲ್ ಕಾಸ್. ಸೊ ನಾನು ಐ ಹ್ಯಾವ್ ವರ್ಕ್ಡ್ ಇನ್ ICU ಫಾರ್ ನಿಯರ್ಲಿ 25 to 26 years ಮಾಡಿದ್ದೀನಿ ಮೇಡಮ್. ಇವಾಗ ನನಗೆ ನಾನು ಏನಾದರೂ ICU ಅಲ್ಲಿ ಐ ಕ್ಯಾನ್ ಸೇವ್ 1 patient ಫಾರ್ ದಟ್ ಅಡ್ಮಿಷನ್. ಇವಾಗ ಒಂದು ಅಡ್ಮಿಷನ್ ನಿಮೋನಿಯಾಗ ಬಂದು ಅಡ್ಮಿಟ್ ಆಗಿದ್ದಾರೆ, ವೆಂಟಿಲೇಟರ್ ಮೇಲೆ ಇದ್ದಾರೆ, ಅದನ್ನು ಸೇವ್ ಮಾಡಿ ಮನೆಗೆ ಕಳಿಸ್ಬಿಡ್ತೀನಿ. ಏನಾದರೂ ಆದರೂ ಸಹಿತ ಕಳಿಸ್ಬೇಕು. ವಾಟ್ ಇಸ್ ದ ಗ್ಯಾರಂಟಿ ದಟ್ ನೆಕ್ಸ್ಟ್ ವೀಕ್ ಅವನು ಬೇರೆ ಇನ್ನೊಂದು ಪ್ರಾಬ್ಲಮ್ ಅಲ್ಲಿ ಬಂದು ಪೇಷಂಟ್ ಅಡ್ಮಿಟ್ ಆಗಿ ಸಾಯ್ಬೋದಲ್ಲ ಮೇಡಮ್. ಬಟ್ ಅದನ್ನೆಲ್ಲ ಮಾಡಿದ್ವಿ. ಇದನ್ನು ಮಾಡಿರೋದ್ರಲ್ಲಿ ವಿ ಕ್ಯಾನ್ ಸೇವ್ ಈಚ್ ಪೇಷಂಟ್ ಫಾರ್ ನೆಕ್ಸ್ಟ್ 15 years ಮೇಡಮ್. ಸೊ ದಟ್ ವಿಲ್ ಗಿವ್ ಅಸ್ ಮಚ್ ಮೋರ್ ಗ್ರಾಟಿಫಿಕೇಶನ್ ಫಾರ್ ಪೀಪಲ್ ಲೈಕ್ ಮೀ. ಸೊ ನಾನು ಅದೇ ಇದರಲ್ಲಿ ಎವ್ರಿ ಡೇ ಅಂದ್ರೆ ವೀಕ್ಲಿ ಅಟ್ಲೀಸ್ಟ್ ಒಂದು 2-3 days ಐ ವಿಲ್ ಗೋ ಮೀಟ್ ಬಿಗ್ ಪೀಪಲ್ ಲೈಕ್ ಯು ಆಲ್ ಪೀಪಲ್. ಸೊ ಎಲ್ಲದನ್ನ ನಾನು ಡಾಕ್ಟರ್ ಸೂರ್ಯರಾಜನು ಅವ್ರ ಸರ್ನು ಮೀಟ್ ಮಾಡಿದೆ. ಸೊ ಅವ್ರಿಗೂ ಹೇಳಿದೆ, ನೋಡಿ ಸರ್, ನಿಮ್ಮ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ಏನಾದರೂ ಬಂದರೆ ಹೇಳಿ ಸರ್, ನಾವು ಎನಿ ಟೈಮ್ ಸಂಡೇ ಇವತ್ತು 8 ಗಂಟೆಗೆ ಫೋನ್ ಮಾಡಿದ್ರೆ ಎತ್ತುತ್ತಾರೋ ಇಲ್ವೋ? ಇಲ್ಲ, ನಾವು ಎತ್ತುತ್ತೀವಿ ಸರ್. ನಾವು ಇವತ್ತು ಹಬ್ಬ ಸಂಕ್ರಾಂತಿ ಇದೆ, ಇವತ್ತು ಬರ್ತಾರಾ ಇಲ್ವಾ? ನಾವು ಬರ್ತೀವಿ. ನಮಗೆ ಇಟ್ಸ್ ನಾಟ್ ಡಸಂಟ್ ಮ್ಯಾಟರ್. ಈ ಸಂಕ್ರಾಂತಿ ಹೋದ್ರೆ ನೆಕ್ಸ್ಟ್ ಬರೋ ವರ್ಷ ಬರುತ್ತೆ ಮೇಡಮ್ ನಮಗೆ. ಸೊ ನಾವು ವಿ ವಾಂಟ್ ಟು ಸಿ ದ ಫೆಸ್ಟಿವಲ್ ಇನ್ ದೋಸ್ ರಿಸಿಪೆಂಟ್ ಫ್ಯಾಮಿಲಿ. ದಟ್ಸ್ ವಾಟ್ ವಿ ಆರ್
Sir, one
ದೇರ್.
flyer, sir, one small flyer ಮಾಡ್ಕೊಟ್ಬಿಡಿ. We will
ಕೊಡ್ತೀವಿ ಮೇಡಮ್,
circulate it to everybody in IMA
Yes,
ಕೊಡ್ತೀವಿ
sir.
ಮೇಡಮ್,
to
ಕೊಡ್ತೀವಿ ಮೇಡಮ್,
create awareness.
ಮಾಡ್ತೀವಿ ಸರ್.
That's all.
ಹಾಂ ಹಾಂ ಮೇಡಮ್.
Thank you. Thank you.
ಸೊ
Even
ಪ್ಲೀಸ್
even
ಪಾಸ್
the
ಆನ್ ದ
fact
ಮೆಸೇಜ್
that
ಮೇಡಮ್.
one more question, sir, ನಾರಾಯಣ್ sir.
ಹೇಳಿ ಸರ್, ಹೇಳಿ ಸರ್.
ಈಗ ಮೇಡಮ್ ಹೇಳ್ತಾ ಇದ್ರು ಅನುರಾಧ ಮೇಡಮ್ ರಿಗಾರ್ಡಿಂಗ್ ಫಾರ್ಮ್ಯಾಟ್ ಫಾರ್ ಐ ಡೊನೇಷನ್, ಫಾರ್ಮ್ಯಾಟ್ ಫಾರ್ ಕಿಡ್ನಿ ಡೊನೇಷನ್, ಇಸ್ ಸೇಮ್ ಆರ್ ಡಿಫರೆಂಟ್?
ಸರ್, ಒಂದು ನಾನು ಸ್ಲೈಡ್ಸ್ ಹಾಕಿ ಟಾಕ್ ಮಾಡೋದಕ್ಕಿಂತ ಮುಂಚೆ ಐ ಓವರ್ ಹಾರ್ಡ್ ಯುವರ್ ಡಿಸ್ಕಷನ್ ಸರ್. ನಾವೆಲ್ಲ ಪ್ಲೆಡ್ಜ್ ಮಾಡ್ತೀವಿ ಹಾಗೆ ಅಂತ ಎಲ್ಲ ಹೇಳ್ತಾ ಇದ್ರು ಸರ್. ಅದು ಲಿವಿಂಗ್ ಡೊನೇಷನ್ ಪ್ಲೆಡ್ಜ್ ಮಾಡೋದು ಯು ಹ್ಯಾವ್ ಟು ಗೋ ಟು ದ ಜೀವ ಸಾರ್ಥಕತೆ ವೆಬ್ಸೈಟ್ ಸರ್. ಅದು ಕರ್ನಾಟಕ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಹೆಲ್ತ್ ಅಂಡ್ ಫ್ಯಾಮಿಲಿ ವೆಲ್ಫೇರ್ ಇದಕ್ಕೆ ಹೋಗ್ಬಿಟ್ಟು ಅದರಲ್ಲಿ ಯು ಹ್ಯಾವ್ ಟು ಗೆಟ್ ಯುವರ್ ಸೆಲ್ಫ್ ರಿಜಿಸ್ಟರ್ಡ್ ದೇ. ಅದಕ್ಕೆ ನಿಮ್ಮ ಸ್ಪೌಸು ಇಲ್ಲ ಚಿಲ್ಡ್ರನು ಇಲ್ಲಾಂದ್ರೆ ಪೇರೆಂಟ್ಸು ದೇ ಹ್ಯಾವ್ ಟು ಪುಟ್ ಎ ವಿಟ್ನೆಸ್ ಅದಕ್ಕೆ ಮಾಡಬೇಕು. ಅಂಡ್ ವಾಟ್ ಆಲ್ ಯು ವಾಂಟ್ ಟು ಡೊನೇಟ್. ಸಮ್ ಪೀಪಲ್ ಆರ್ ದೇ ವಿಲ್ ಗಿವ್ ಎ ಜನರಲ್ ಸ್ಟೇಟ್ಮೆಂಟ್, I will donate all my organs anta. Some people want only these things need to be donated anta. You need to be specific sir. Adana ನೀವು ಅದನ್ನ ಮಾಡಿ ರಿಜಿಸ್ಟರ್ ಮಾಡಿದ್ರೆ they will talk to you when it happens sir. ಆ ಥರ ಅದು that's the way to get it registered.
Thank you, sir.
Thank you sir.
ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಸ್ವಾಮಿ ಸರ್. ಏನಿಲ್ಲ, ಒಂದು ನನಗೆ ಅರ್ಥ ಆಗಿದ್ದು ಏನು ಗೊತ್ತಾ ಸರ್, ಈಗ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಆಕ್ಟ್ ಇದೆಯಲ್ಲ ಸರ್,
ಹಾಂ ಸರ್,
ಅದು ಬಹಳವರೆಗೂ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ನ ಸ್ಲೋ ಡೌನ್ ಮಾಡಿದೆ ಸರ್. ಅಂದ್ರೆ ಗವರ್ನಮೆಂಟ್ ಥಿಂಕ್ ಮಾಡ್ತಿರೋದು ಇಲ್ಲಿಗಲ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಆಗ್ಬಾರ್ದಂತ ಒಂದು ಒಳ್ಳೆ ಉದ್ದೇಶ
ಮಾಡಿದ್ದಾರೆ ಸರ್. ಹೌದು ಹೌದು ಸರ್, ಹೌದು ಸರ್.
ಬಟ್ ಅದ್ರಿಂದ ಏನಾಗ್ತಿದೆ ಅಂದ್ರೆ ಸರ್, ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ರೇಟ್ ಆಫ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ತುಂಬಾವರೆಗೂ 90% ಕಡಿಮೆ ಆಗಿದೆ ಅಂತ ನಿಮ್ಗೂ ನಮ್ಗೆ ಎಲ್ಲ ಗೊತ್ತು.
ಹೌದು ಸರ್.
ಈ ತರ ಸರ್ ಮೋಸ್ಟ್ಲಿ ಈಗ ನೋಡಿ ಸರ್, ಒಂದು 30 ವರ್ಷದಿಂದ ಕಾರ್ಡಿಯಾಕ್ ಬೈಪಾಸ್ ಸೆಂಟರ್ಸ್ ಓನ್ಲಿ ಚೆನ್ನೈದಲ್ಲಿ ಇತ್ತು.
ಚೆನ್ನೈದಲ್ಲಿ ಅಪೋಲೋದಲ್ಲಿ ಇತ್ತು ಸರ್.
35-40 years ಬ್ಯಾಕ್.
ಹೌದು ಸರ್, ಅಪೋಲೋದಲ್ಲಿ ಇತ್ತು.
ಇವತ್ತು ಇಡೀ ಮೀನ್ಸ್ ಇಡೀ ಕರ್ನಾಟಕದಲ್ಲಿ ಪ್ರತಿಯೊಂದು ಪ್ಲೇಸ್ ಅಲ್ಲೂ ಕೂಡ ಕಾರ್ಡಿಯಾಕ್ ಸೆಂಟರ್ಸ್ ಇದಾವೆ.
ಕಾರ್ಡಿಯಾಕ್ ಸರ್ಜರಿ ಆಗುತ್ತೆ ಸರ್. ಹೌದು ಸರ್.
ಇದೇ ತರ ಆರ್ಗನ್ ಡೊನೇಷನ್, ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ನಡೆಯುವಂತಹ ಸೆಂಟರ್ಸ್ ಕೂಡ ಒಂದು ಹೆಂಗ್ ಕ್ರಿಯೇಟ್ ಆಗ್ಬೇಕಪ್ಪ ಅಂದ್ರೆ ಆರ್ಗನ್ ಡೊನೇಷನ್ ಈ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಆಗುತ್ತೆ, ಇಷ್ಟು ಈಸಿಯಾಗಿ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಆಗುತ್ತೆ ಅನ್ನುವಂತಹ ಫೀಲ್ ಕ್ರಿಯೇಟ್ ಆದ್ರೆ ಸರ್, ವಿತ್ ಚೇಂಜಸ್ ಐ ಥಿಂಕ್ ವಿತ್ ಈಗ ಡಿಮ್ಯಾಂಡ್ ಜಾಸ್ತಿ ಇದೆ ಮತ್ತೆ ಸಪ್ಲೈ ಕಡಿಮೆ ಇದೆ ಅಂಡ್ ಥಿಂಗ್ಸ್ ವಿಲ್ ಚೇಂಜ್ ಅಂತ ಅನ್ಸುತ್ತೆ ಸರ್. ಐ ಥಿಂಕ್ ತಮ್ಮ ಎಫರ್ಟ್ ನ ರಿಯಲಿ ಸೆಲ್ಯೂಟ್ ಅಂಡ್ ಅಪ್ರಿಷಿಯೇಟ್ ಸರ್. ತಾವು ಹೇಳ್ತಾ ಇದ್ರಲ್ಲ, ಅದು ಆರ್ಗನ್ ರಿಟ್ರಿವಲ್ಗೆ ನಾವು ಬಂದ್ಬಿಟ್ಟು ಅವ್ರಿಗೆ ಅವೇರ್ನೆಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿ, ಓರಿಯಂಟೇಷನ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಅಂತ ಒಂದು ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿ ಆಮೇಲೆ ರಿಟ್ರಿವಲ್ ಮಾಡ್ತೀವಿ ಅಂತ ಹೇಳಿದ್ರಲ್ಲ ಸರ್, ದಟ್ ಇಸ್ ವೆರಿ ವ್ಯಾಲಿಡ್ ಪಾಯಿಂಟ್. ವಿ ಹ್ಯಾವ್ ಅವರ್ ಡ್ಯೂಟಿ ಈಸ್ ಮೈಂಡ್ ಸೆಟ್ ಶುಡ್ ಚೇಂಜ್ ಸರ್. ಈಗ ಕ್ಯಾಶುಯಾಲಿಟಿ ಪೇಷಂಟ್ ಬಂದ ತಕ್ಷಣನೇ, ಈಗ ಬ್ರೈನ್ ಆದ ತಕ್ಷಣನೇ ಈ ಬ್ರೈನ್ ಡೆತ್ ಆಯ್ತು ತಾವೊಂದು ಮಾತು ಹೇಳಿದ್ರಿ, ಅದನ್ನ ನೆಗ್ಲೆಕ್ಟ್ ಮಾಡ್ತಾರೆ ಜನ ಅಂತ. ಮೈಂಡ್ ಅಲ್ಲಿ ಯಾವ ತರ ಸೆಟ್ ಆಗ್ಬೇಕಪ್ಪ ಅಂದ್ರೆ ಇದು ಆರ್ಗನ್ ಡೊನೇಷನ್ ಹೆಲ್ಪ್ ಆಗುತ್ತೆ ಈ ಪೇಷಂಟ್. ಆ ಆಂಗಲ್ ನೋಡಿದಾಗ ಒಂಥರ ಮೈಂಡ್ ಸೆಟ್ ಚೇಂಜ್ ಆದಾಗ ದೆನ್ ಆರ್ಗನ್ ಡೊನೇಷನ್ಸ್.
ಸರ್, ನಾನು ಒಂದು ವಿಷಯ ಹೇಳ್ತೇನೆ ಸರ್. ಇವಾಗ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಒಂದು ಪೇಷಂಟ್ ಬಂದಿದೆ ಸರ್, ERಗೆ ಬಂದಿದೆ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ. ಅದು ನೋಡಿದಾಗ ಪೀಪಲ್ ಡೈರೆಕ್ಟೆಡ್ ಫಿಕ್ಸ್ಡ್ ಇದೆ, ಬ್ರೈನ್ ಸ್ಟೆಮ್ ರಿಫ್ಲೆಕ್ಸಸ್ ಇದ್ದಂಗಿಲ್ಲ. ಫ್ಯಾಮಿಲಿ ಹೇಳ್ತಾರೆ ರೋಡ್ ಟ್ರಾಫಿಕ್ ಆಕ್ಸಿಡೆಂಟ್ ಆಗಿದ್ದು, ಹೀಗಾಗಿದೆ ಹೀಗೆ ಅಂತ. ಯು ವಿಲ್ ಇಮಿಡಿಯೇಟ್ಲಿ ಅವನಿಗೆ ನೀವು ನ್ಯೂರೋ ಸರ್ಜನ್ ಇಂಟರ್ವೆನ್ಷನ್ ಮಾಡಿದ್ರು, ಇನ್ನೇನು ಬದುಕಲ್ಲ ಅಂತ ನಿಮ್ಗೆ ಗೊತ್ತಿತ್ತು ಸರ್. ಅವಾಗೆ ಬೆಸ್ಟ್ ವೇ ನಾವು ಏನು ಮಾಡಬೇಕು ಅಂದ್ರೆ, ಇವಾಗ 100 ಸುಳ್ಳು ಹೇಳಾದ್ರೂ ಒಂದು ಮದುವೆ ಮಾಡಬೇಕು ಅನ್ನಂಗೆ, ಆವಾಗ ಆ ಮೂಮೆಂಟಿಗೆ ವಿ ಹ್ಯಾವ್ ಟು ಶಿಫ್ಟ್ ಹಿಮ್ ಟು ದ ICU. ICUಗೆ ಶಿಫ್ಟ್ ಮಾಡಿ ವೆಂಟಿಲೇಟರ್ ಕನೆಕ್ಟ್ ಮಾಡಿ ಇಟ್ಕೊಂಡು we have to give time to the family to understand. Then gradually ಅವ್ರಿಗೆ ಇನ್ಫಾರ್ಮೇಶನು ಸ್ವಲ್ಪ ಪೀಸ್ ವೈಸ್ ಕೊಡ್ತಾ ಇರಬೇಕು, ಹೀಗೆ ಅಂತ. ಮೀನ್ ವೆಲ್ ಅಟ್ ದ ಸೇಮ್ ಟೈಮ್ ಯು ನೀಡ್ ಟು ಆಕ್ಟಿವೇಟ್ ದ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಟೀಮ್ಗೂ ಆಕ್ಟಿವೇಟ್ ಮಾಡಬೇಕು. ಅವರಿಂದ ಏನಾದರೂ ಹೆಲ್ಪ್ ಬರುತ್ತಾ, ನಮ್ದು ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದ್ರೆ ಕ್ಲಿಯರ್ ಆಗುತ್ತಾ ಅಂತ ಅದೊಂದು ಮಾಡ್ಬೇಕು ಸರ್. ಸರ್ ಇನ್ನೊಂದು ನಿಮ್ಗೆ ಫಸ್ಟ್ ಕ್ವಶನ್ ನಿಮ್ಗೆ ಹೇಳಿರೋದು ಅದನ್ನ ಸರ್, ನಾನು ವಾಟ್ ಐ ಹ್ಯಾವ್ ಸೀನ್ ಇಟ್ಸ್ ದ ಈ ನ್ಯಾಷನಲ್ ಲೆವೆಲ್ ಪ್ರೋಗ್ರಾಮ್ನ ನಾನು ಬೋಲ್ಡ್ ಆಗಿ ಹೇಳ್ತೀನಿ ಸರ್. ಐ ಥಿಂಕ್ ಪ್ರಾಬಬ್ಲಿ ಯಾರಾದ್ರೂ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಇದ್ದೀರಾ ಸರ್? ಇಲ್ಲಿ ಯಾರಾದ್ರೂ ಇದ್ದೀರಾ ಸರ್?
ಇದೆ ಸರ್.
ಹಾಂ ಸರ್. ಸರ್ ಐ ವಾಂಟ್ ಟು ಸರ್, ಯಾರು ತಪ್ಪು ತಿಳ್ಕೊಬಾರ್ದು ಸರ್. ನಾನು ಐ ಹ್ಯಾವ್ ಸೀನ್ ಸರ್, the majority of these brain dead patients come to a medical college hospital. I have seen, sir. I've gone and met a lot of people in the medical colleges. All medical colleges ko nanu hogidini sir. Illi what happens, alli highest number of patients iro hogodu, identify agodu alle. Alli nobody is interested sir medical college alli. Alli ಏನಂತಾರೆ, ಇದೆಲ್ಲ ಮಾತಾಡಬಾರ್ದ್ರಿ, ಇಲ್ಲಿ ಜನರು ಸರಿ ಇಲ್ಲ ರೀ. ಅವರು ಇನ್ನೊಂದು ಏನು ಅಂತಂದ್ರೆ, they all want to go home around 4 o'clock. ಅದು ಫಿಂಗರ್ದು ಅದೇನೋ ಇದನ್ನ ಮಾಡ್ಬಿಟ್ಟು ಸ್ವೈಪ್ ಮಾಡಿ ಮನೆಗೆ ಹೋಗ್ಬೇಕು. Nobody want to take care. Medical colleges are the people, medical colleges are the one who are letting down the nation, sir. ನಾನು ಇವತ್ತು ಬೋಲ್ಡ್ ಆಗಿ ಹೇಳ್ತೀನಿ ಸರ್. ಇಟ್ಸ್ ದ ಸ್ಮಾಲ್ ಹಾಸ್ಪಿಟಲ್ಸ್ who are actually carrying the nation's burden. Actually ಸ್ಮಾಲ್ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಕ್ವಿಕ್ ಆಗಿ ಡಿಶ್ ತಗೊಂತಾರೆ, ದೇ ವಿಲ್ ಟೇಕ್ ಕೇರ್, ಇಮಿಡಿಯೇಟ್ ಆಗಿ ಫೋನ್ ಮಾಡ್ತಾರೆ, ನೀವು ಬರೋದಂಕ ನಾವು ನೋಡ್ಕೊಂತೀವಿ ಅಂತಾರೆ. ವಿತ್ ಲಿಮಿಟೆಡ್ ರಿಸೋರ್ಸಸ್ ದೇ ಆರ್ ಡೂಯಿಂಗ್ ಆಲ್ ದಿಸ್ ಥಿಂಗ್ಸ್. ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗೆ ದೇ ರಿಕ್ವೈರ್ UGC ಫಂಡ್ಸು, UGC ಗ್ರಾಂಟ್ಸ್ ಸಿಗುತ್ತೆ, ಎಲ್ಲ ಸಿಗುತ್ತೆ. ಏನು ಮಾಡಲ್ಲ ಸರ್. ಇಫ್ ಯು ಗೋ ಟು ದ ಎಮರ್ಜೆನ್ಸಿ ಅಂಡ್ ಸಿಟ್ ಇನ್ ದ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್, ಎವ್ರಿ ಡೇ ನೈಟ್ ಒಂದು ಪೇಷಂಟ್ ಬರುತ್ತೆ. ICUಗೆ ಹೋದಾಗ ಇರುತ್ತೆ. ವೆನ್ ಯು ಟಾಕ್ ಟು ದ ಇಂಟೆನ್ಸಿವಿಸ್ಟ್, ಮೀಟ್ ಮಾಡ್ಕೊಂಡಿದ್ರೆ, ದೇರ್ ಇಸ್ ನೋ ಸಚ್ ಕೇಸ್ ಸರ್ ಅಂತಾರೆ ಇಂಗ್ಲೀಷಲ್ಲಿ. ದೇರ್ ಇಸ್ ನೋ ಸಚ್ ಕೇಸ್, ಇಲ್ಲೇ ಇಲ್ಲ. ಒಂದು ತಿಂಗಳು ಇರಲ್ಲ, 6 months ಮೇಲೆ ಎನ್ಕ್ವೈರಿ ಮಾಡಿ ಬಂದೇ ಇಲ್ಲ ಸರ್ ಅಂತ ಹೇಳ್ತಾರೆ. ಇನ್ನೂ 6 months ಬಿಡಿ, ಇಲ್ಲ ಸರ್ ನೋ ಸಚ್ ಕೇಸ್ ಸರ್ ಅಂತಾರೆ. ಇಫ್ ಯು ಗೋ ಥ್ರೂ ದ ರಿಜಿಸ್ಟರ್, ಎವ್ರಿ ವೀಕು ಒಂದು ಅಡ್ಮಿಟ್ ಆಗಿರುತ್ತಲ್ಲ. ದೇ ಡೋಂಟ್ ಹ್ಯಾವ್ ದಟ್ ಇಂಟೆನ್ಷನ್ ಸರ್. ದೇ ಆರ್ ದ ಪೀಪಲ್. ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಅವರು ಸರ್, ನಾನು ಐ ಆಮ್ ವೆರಿ ಸಾರಿ ಟು ಟೆಲ್ ಸರ್, ಇಟ್ಸ್ ದ ಸ್ಮಾಲ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ವಿಚ್ ಐ ಹ್ಯಾವ್ ಸೀನ್, ದೇ ಆರ್ ಟೇಕಿಂಗ್ ದ ಎಕ್ಸ್ಟ್ರಾ ಎಫರ್ಟ್ ಟು ಹೆಲ್ಪ್ ದ ಸೊಸೈಟಿ. ಇದನ್ನು ಮಾಡೋದಂದ್ರಲ್ಲಿ ನಾನು ನೋಡಿದ್ದೀನಿ ಸರ್, ಭಾಳ ಜನ ನಾನು ನೋಡಿದ್ದೀನಿ. ಹೋದಾಗ ಫಸ್ಟು ಏನಂತಾರೆ, ಒಂದು ನಮ್ಮ ಕಾಲೇಜಲ್ಲಿ ಗೆಸ್ಟ್ ಲೆಕ್ಚರ್ ಆಗಿ ಒಂದು ಟಾಕ್ ಮಾಡಿ ಅಂತಾರೆ, ವಿಲ್ಡು ಅಷ್ಟೇ, ಅಲ್ಲಿಗೆ ಮುಗಿದೋಯ್ತು ಸರ್. ಆಮೇಲೆ ಏನು ಮಾಡಲ್ಲ ಸರ್ ಹೆಲ್ಪ್. ನಾನು ಎಷ್ಟೋ, ಬಟ್ ಐ ಆಮ್ ನಾಟ್ ಲೂಸಿಂಗ್ ಮೈ ಪೇಷನ್ಸ್. ನಾನು ಇವಾಗೂ ಹೋಗ್ತೀನಿ, ಎಲ್ಲರೂ ಮಾತಾಡ್ತೀನಿ. ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ಇಂಟ್ರೆಸ್ಟ್ ಇರುತ್ತೆ ಸರ್, ಚೇರ್ಮನ್ಸ್ಗೆ, ಬೋರ್ಡ್ ಮೆಂಬರ್ಸ್ಗೆ, ಎಲ್ಲರಿಗೂ ದೇ ವಾಂಟ್ ಟು ಗೆಟ್ ಇಟ್ ಡನ್. ಎಲ್ಲ ಕೆಳಗೆ ಡಾಕ್ಟರ್ಸ್, ದೇ ಮೈಟ್ ಬಿ ಅರೌಂಡ್ 30 years 35 years, ಇಂಟ್ರೆಸ್ಟ್ ಇಲ್ಲ ಸರ್ ಅವ್ರಿಗೆ ಯಾರಿಗೂ. ದೇ ಜಸ್ಟ್ ಹೋಗ್ಲಿ ಬಿಡಪ್ಪ, ಅದೆಲ್ಲ ಮಾಡ್ಕೊಂಡಿದ್ರೆ ಅದಕ್ಕೆ ಸುಮ್ಮನೆ ಪ್ರಾಬ್ಲಮ್ ಅಲ್ಲಿ ಸಿಕ್ಕಾಕೊಂತೀವಿ. ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ಸರ್. ಇದು ಎವ್ರಿಥಿಂಗ್ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಮೇಡ್ ಇಟ್ ಲೀಗಲ್, ಮ್ಯಾಂಡೇಟ್ರಿ. ಯು ಹ್ಯಾವ್ ಲೀಗಲ್ ಪ್ರೊಟೆಕ್ಷನ್, ಯು ಹ್ಯಾವ್ ಟು ಟಾಕ್ ಅಂತ ಸುಪ್ರೀಂ ಕೋರ್ಟ್ ಹೇಳಿದೆ. ಇವ್ರು ಮಾಡಲ್ಲ ಸರ್. ಇವ್ರಿಗೆ ಪ್ರಾಬ್ಲಮ್ ಬಂದಾಗ ಯು ವಿಲ್ ಕಮ್ ದೇರ್, ಏನೋ ನೋಡ್ರಿ, ಏನಾದ್ರು ಒಂದು ಮಾಡ್ಬಿಡ್ರಿ ಅಂತಾರೆ. ಆಗಿರುತ್ತೆ ಸರ್.
Sir, sorry to interfere. 3 years back, when I was Bangalore branch president, at the national level, organ donation had been taken up, and we were all requested to speak, give talks, and organize and create awareness about organ donation. We
Okay,
did do quite a bit. I mean, in the sense, nam level ಅಲ್ಲಿ ಎಷ್ಟಾಯ್ತು ಅಷ್ಟು ಮಾಡಿದ್ವಿ. Now we are going to request our secretary, Dr. Surya Raju, to send a circular to all branches, and in particular to all the 60 medical colleges here in Karnataka, that some awareness, whatever it is. We will kindly prepare a format, sir, on our behalf, so that format, he is going to send a mail to all of us, all branches, as well as to all medical colleges.
And one more good news is our president, Dr. V.V. Chinnawala, sir, he stressed too much on organ donation. Wherever he
Okay,
goes
sir.
to this branch visit ಕೊಡ್ತಾರಲ್ಲ ಸರ್, ಅವರು ಆರ್ಗನ್ ಬಗ್ಗೆ ಎಷ್ಟು ಇಂಟ್ರೆಸ್ಟ್ ಇದೆ ಅಂದ್ರೆ, ಅದ್ರ ಬಗ್ಗೆ ಅವೇರ್ನೆಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿ, ಅದ್ರ ಬಗ್ಗೆ ಆರ್ಗನ್ ಡೊನೇಷನ್ ಬಗ್ಗೆ ನೀವು ಮುಂದೆ ಸ್ಟೆಪ್ ಹಾಕ್ಬೇಕಂತ ಹೇಳಿ ಅವರು ತುಂಬಾ ಇನ್ಸಿಸ್ಟ್ ಮಾಡ್ತಾರೆ ಸರ್. ಡೆಫಿನೆಟ್ಲಿ ವಿ ಟೇಕ್ ಇಟ್ ಫಾರ್ವರ್ಡ್. ಅಂಡ್ ದಿಸ್ ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಸ್ವಾಮಿ ಸರ್ಸ್ talk will definitely stimulate us to take it forward and reach more people, more doctors, and
Correct, sir.
to create awareness and mindset should change. Each of us doctors should think in that direction. ನಾಳೆ ನನಗೇನಾದರೂ ಆದರೆ ಆರ್ಗನ್ ಡೊನೇಷನ್ಗೆ ಯಾರು ಮುಂದೆ ಬರದೇ ಇದ್ರೆ ನನ್ನ ಯಾರು ಜೀವ ಉಳಿಸ್ತಾರೆ ಅನ್ನುವಂಥ ಮೈಂಡ್ಸೆಟ್ ಬರಬೇಕಾಗಿದೆ.
Correct, sir. Correct, sir. Correct, sir.
Definitely, sir, we will take it forward, sir. You can give us the guidelines, sir, and we will circulate.
Sure, sir. Sure, sir. Thank you, sir. Thank you.
Sir, this talk will be there in the YouTube forever. ಡಾಕ್ಟರ್ ಸೂರ್ಯರಾಜು ಸರ್, ಇದನ್ನ ಮತ್ತೆ ಇನ್ನೊಂದ್ಸಾರಿ ನಮ್ಮ ಮೆಂಬರ್ಸ್ ಎಲ್ಲರಿಗೂ ಒಂದ್ಸಾರಿ ಆ ಯೂಟ್ಯೂಬ್ ನೋಡೋದಕ್ಕೆ ಇದ್ ಮಾಡಿ, those who have not attended.
ವಾಟ್ಸ್ಆಪ್ ಗ್ರೂಪಿಗೆ ಹಾಕಿ ಸರ್.
ಮಾಡ್ತೇನೆ.
Thank you, sir.
Let us conclude, Dr. Suresh.
Yeah, Rohini madam.
Yes, sir. Sir, it was a very informative talk, sir, especially giving us a knowledge about who is a suitable donor ಯಾರು, ಮತ್ತೆ ಬ್ರೈನ್ ಡೆತ್ ಆದಾಗ ಏನ್ ಮಾಡ್ಬೇಕು, ಹೇಗೆ ಫ್ಯಾಮಿಲಿ ಜೊತೆ ಮಾತಾಡ್ಬೇಕು, ಮತ್ತೆ you also have given us information, ಯಾರಾದ್ರೂ ಡೊನೇಟ್ ಮಾಡೋದಿದ್ರೆ ಎಲ್ಲಿ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡ್ಬೇಕು, ಲೈಕ್ ಜೀವನ್ ಸಾರ್ಥಕತೆ and all that. And you have also quoted us important and very interesting cases you have come across in your lifetime service. And so on behalf of Public Health Committee, I thank you for this, sir, Dr. Narayanaswamy, sir.
Thank you, madam. Thank you, madam.
I thank Dr. Suriraju, sir, Secretary IMA KSP, for joining and giving us the inputs. I thank Dr. Anuradha Parameshwar, madam, for also joining and giving her inputs. I thank Dr. Suresh Kagalkar, sir, Chairman, Public Health Committee, for organizing and conducting this webinar on a very important topic. I thank Dr. Rajendra Prasad, sir, for joining in here, and also all the members of Public Health Committee and the seniors and delegates who have joined with us for today. I thank all the office bearers and Mr. John working behind the scene, making it a successful webinar. Thank you all, sir. Thank you all.
Thank you, sir. Thank you. Good night, sir.
Thank you, sir.